Okay, hello and welcome everybody to this Dystonia Day of 2026. It's a great honor to host you here in Sweden. If you come from abroad, welcome. If you come from Sweden, welcome to Malmö. And if you come from Malmö, welcome. My name is Mats Nyberg and I'm the president of the Swedish Dystonia Association. We have a great program in front of us. I hope you have all seen it. We start with a lot of different lectures and discussions during the day, and then tonight we have the tour to a Viking village or a Viking site somehow, following it with a dinner directly after. I'm happy to see so many people here. And I hope we have a great day together. I'm sure we will.
Thank you, Mats. Good morning, everyone. I met quite a few of you yesterday, and some of you I've actually known for quite a long time now. But for the new faces that I haven't met before, my name's Jill Ainsley. I'm from the UK, and as of yesterday, I'm the president of Dystonia Europe, which is a huge privilege for me. So I would also like to welcome you all and thank you all for travelling. I know some of you will have had very long travels, and myself included. So thank you all for making the effort to be here. And as Matt says, we have a great programme, and please just sit back and enjoy.
So, hello everybody, my name's Rachel Jones. I've known Dystonia Europe for, I think it's probably about 5 years, actually, Monica, isn't it? I think 5 or 6 years, so I'm your moderator for today. So I'm here really just to glue it all together for the reason that you can just all sit back and relax and not think about anything else, but I'll glue it all together for you today. So we're going to start with this morning, we're going to do the present, which is what it's like to live with dystonia as both a patient and both as a relative of people who live with dystonia, and the current treatment. So we're going to start with the present. Then in the afternoon, we're going to switch kind of, if you like, rhythm, and we're going to look at the future and what the possibilities hold. So with that in mind, all these events are always really good to start with patient or person-centered, person living with dystonia. So we have a video to show just to open, and this is by a gentleman who you may know, who is Salvatore Caruso. So sadly he can't be with us today, but he is a person living with dystonia, and many of you may know he also sits on the board as well, and he's going to take us through the day-to-day living with dystonia.
Hello everyone, some of you already know me. My name is Salvatore Caruso. I'm board member in the Italian Dystonia Association and also in Dystonia Europe. And I have myoclonic dystonia, and 2022, so 4 years ago, I underwent deep brain stimulation. And yes, and first of all, I would like to apologize for not being able to be here in person today. I truly wanted to attend, but unfortunately, I have not been well enough in recent days to make it. But nevertheless, I would like to take this opportunity to share a few words about living with dystonia, but also about identity, about the question who we are when the body, let's say, betrays us, and about what emerges when we stop fighting against it. And for this, I think dystonia, it's, let's say it was for me not only a diagnosis, it's like, it was always like a philosophical teacher, let's say. And yeah, I mean, most people take their body for granted. It does what they want, and it works. So they don't have to think about it. But for us, it's different. When your body moves against your will, I mean, who is the one who's watching? When your hand turns away, even though your brain says stop, where does the illness end and where do I begin? So, and I mean, this may sound like a philosophical question, but for me, it was the most real question of my life. And as a child and teenager, my body showed things I did not want to show. And I was bullied for that. I was left out. And slowly I started to believe what others seem to see. A boy who is different, an outsider, and someone who doesn't belong. And that was perhaps the deepest wound. Not only the movement themselves, but the moment I stopped believing that there was a person inside worth fighting for. And yes, but there is a moment many people with dystonia know, and it doesn't show up in medical files. It is the moment when you decide, I am more than what people think of me. And I mean, yes, for me, that moment came when I was around 18, let's say. It wasn't a dramatic moment. It was quiet moment. Like the first warm day after a long winter, and I stopped seeing music as an escape. I started seeing it as a language, a place where I could simply exist, where who I was on the inside was stronger than what my body was doing on the outside. And this was music is one of the examples of things that helped me in this period of time. And I learned something important. So resilience is not something you are born with. It is something you choose every single day, again and again. So that is what connects us as a community, not the pain. But this is quiet. Daily choice to keep going, let's say. And yes, as I said, in 2022, I had deep brain stimulation surgery at the Istituto Neurologico Carlo Vesta in Milan. And yeah, so electrodes in the brain, electrical signals changing something in my head. And I have thought a lot about what this really means, because it raises a question that is relevant for all of us, I think, including those of you in the medical field. What does it mean to be yourself when a device helps shape how you move and feel? And my answer is simple. So I did not become less myself after this surgery. I became myself for the first time. And when the involuntary movements got better, I realized something. I had spent decades using almost all of my energy just to cope with my own body. And now, for the first time, there was silence. And in that silence, I could finally hear myself. And yes, I could finally hear myself and what I think, what I want, and who I am. And I mean, a glass of water without a straw, that sounds like a small thing, but for me it was everything. And we don't realize how much it means to feel at home in your body until you finally do. And with that being said, as you know, we live in a world that is moving faster and faster, more information, more noise, more division. People feel out of control and they respond by shouting louder. I believe that those of us who live with dystonia know something important, something the world needs right now, I think. So we have learned to live with things we cannot control. And we have learned that you don't need to control everything to live a good life. You need to know what you can change and find peace with what you cannot. And that is not giving up. In my opinion, that is wisdom. And it is something our community, patients, families, and doctors together can offer to the world if we choose to share it. And I believe we are doing good as a community, but I believe we can do more as a community, as a dystonia community. We have incredible people among us, patients with deep emotional intelligence, shaped by years of difficult experience, doctors and researchers pushing the limits of what medicine can do, and stories that have the power to move people. And together, I think we can be a strong shared voice. Yes, dystonia is rare enough to be ignored and common enough to deserve real attention, in my opinion. So attention for the people who are diagnosed late, for the children who are bullied, for everyone who has ever felt alone in this condition. And I always wanted to help change that, not just because it is my story, but because I believe we have something important to say, and maybe something that goes far beyond our own community. So, ladies and gentlemen, that body that made my life so hard also made me who I am. And it taught me what it means to stay dignified under pressure, what real friendships look like when you grow up feeling different, and what real joy feels like, the kind you find in small, simple moments. So I learned that only those who know what it feels like to not be themselves truly know who they are. Thank you.
So I wish the guy who just, I wish could hear the I guess the emotion and the kind of response from you all. I hope we can convey that back as well, Monica, back to him. But it's now my pleasure to introduce one of our first speakers, who is Professor Marina de Koning-Tijssen from the Netherlands, and she'll take us through, I believe, a general overview of dystonia with a discussion of one subpart of it as well. But the main thing, the most important thing is that, Marina, you've actually been on the board as well, I believe, for 5+ years. So welcome to the stage.
Well, thank you so much, and thank you, Dystonia Europe, and especially Monica, for inviting me. As said, I've been on the board for about 5 years when there were still doctors on the board, which I think is a good thing that they're not anymore because it's a patient society. But I'm still on the medical advisory board, and I'm always, Dystonia Europe is close to my heart. And as my husband is working in Lund, it was a real pleasure that I could come to Malmö, so I could join him in Lund for a few days. And what I would like to do today with you is talk you through some new developments in dystonia in general, and then have a few slides specifically on myoclonus dystonia. I'm pushing the green button. Yeah, it's working. No. You can see my disclosures, and especially the bottom one. We're going to have the big Movement Disorder Society meeting next year in Amsterdam. So I'm very pleased that I will be involved there as the chair of the local organizing committee. I try again? No. I can also press on the computer if that's easier. Try once more. Yeah. Okay. So I have a short introduction to dystonia. Then I tell you a bit about the new classification of dystonia, a novel way how to approach patients with an adult onset form of dystonia, and then a bit about myoclonic dystonia. Well, for you it's good to know that although it doesn't make a difference in daily life, that there is a new definition in dystonia. And especially we took out muscle contractions because that was confusing, as people thought it was a muscular disorder, while it is a brain disorder. And the jerky movements are added. So how we define it in the medical field is it's a movement disorder characterized by persistent or intermittent abnormal movement, postures, or both. And they're typically patterned. Every patient has his own dystonia with their own pattern. Can be different between patients, but it's the same within one patient. It's repetitive, and it can be with tremor or it can be jerky. And it's usually triggered or gets worse when you're doing something. And then not only the part that's moving gets worse, but also other parts of the of the body, which is called overflow. Well, roughly said, there are two types of dystonia, and by far the largest group is the focal dystonia. So that's mainly cervical dystonia, that's the largest group, but it's also blepharospasm or hand dystonia. And when patients get a focal dystonia, they usually remain in that area. It can spread a little bit, but it's not expected to spread to the whole body. And usually there is no cause. On the other hand, there is a small group of about 5% of patients who have an early onset, so in childhood have start of the dystonia. Then it usually starts in a leg or in an arm, and that form tends to generalize. So those patients get generalized dystonia. And in many patients, not all at the moment, but in many we find a genetic cause of their dystonia. So those are two groups that really have a different clinical pattern and a different course over time. And just to show you, although you all know what dystonia is, this is a patient with cervical dystonia. We always look from the front, from the back and from the side to see what is the posture. And here is the same patient. When she's writing, she has writer's cramp. As you could see, she has a young onset dystonia, so she has more generalized form of dystonia. You see the cramping of the hand with a different posturing when she's writing. And what we always do then is that we ask patients to write with their left hand, so we can see the thumb goes up. And the reason to do this is when you give botulinum toxin, you want to know which muscles are active, but even if the thumb goes up, you will press it down because otherwise you cannot hold the pen. So by writing with the left hand, you can see what the dystonic posturing is, because if you give botulinum toxin, you have to work on the upward and not on the downward, although it looks that way when people are writing. And this is something that many of you probably also know, that there are tricks in dystonia that can reduce the dystonia. The most common one is touching the face, but here you can see there are other things as well. This is a late onset dystonia, cervical dystonia patient, and she noticed, as you can see in a minute, when she's knitting, although it's an action and you would expect it to get worse, but for her it works very well. Then her head is much less restless. So for her it's really relaxing to do this. And there are patients who are singing, especially patients with blepharospasm, and their eyes go open. So when they do their shopping, they do that. There are patients with oromandibular dystonia who chaw on gum to get improvement, but also cervical dystonia patients who like it to wear something around their neck, and then the dystonia gets better. But it's different for everyone, but it's interesting to see how patients find their own tricks. But it might sometimes be relevant for you as well to, well, just to try some things that might help you in daily living. And then on the other hand, as I said, there is generalized dystonia. This is a young man who is deaf, and from puberty he had progressive dystonia. And as I told you before, it started in a limb and it generalized, and then suddenly it got much worse. And because he is deaf, and with all this dystonic posturing and also in the face, it was difficult for him to see because there was a lot of blepharospasm. So he was really disabled, and in this patient we decided to give DBS, and there will be another talk on DBS in this morning session, but just to show you, this is him after DBS, and especially the eyes were open, so he could see again, which was for him a great value because he couldn't hear. So he life really improved and he could walk. It's not always that good, but for him it worked out very well. Okay, so now just a bit about the new classification. You might have heard about it or not. It's something that sometimes just runs in the medical field and patients are not aware of that. In 2013 there was a new classification and we did that for different kind of movement disorders, also for tremor, and there is now one on the myoclonus, to have a systematic way to describe a patient's dystonia. So on the left side, this is what we call the axis 1, that describes the clinical features. So what age did it start? Where did it start in the body? Is it progressive or is it variable or is it stable? But also, are there other features like is there another movement disorder coming together with the dystonia, or is it just dystonia? And are there other neurological features like deafness or other things? I come back to that in a second. And then based on that, you get a total picture of a patient, and you can go to axis 2, the etiology. And by describing very well in axis 1, it helps you to look in axis 2 for the diagnosis. And in 2025 we updated this classification, and the reason for that is that we noticed that there were some patients that didn't fit well in the classification, and we needed some extra features to add to have, because when we are going to look for etiology, it's good to have a group of patients that have the same picture. So we added, I just blurred it because it's too complicated, but we added some things in the clinical side, which is here the axis 1, but also on the axis 2 on the causes, on the etiology. And this is what came up, and the reason for that is that there are patients who have a genetic form of dystonia, so there is a gene involved. You can have an acquired form, which means something happens to you, like a brain infarction or an infection or anything like that. Then you call it an acquired form. But there are also patients who have lesions for other reasons, so there is an anatomical reason for that, and we couldn't fit that in the previous classification. And also pathogenesis, which means some patients have a metabolic disorder and that causes their dystonia. So you know sort of what the cause is, but it couldn't fit in the previous one. So what we do on the clinical side, we describe the patient, then you get a clinical syndrome, and then you go to the etiology. And just to give you a few examples of that, I told you if it's a young onset age and generalized or starts in a leg, you're going to go for a genetic analysis. If it's focal, starting at a later age, it's probably non-genetic and you will probably find no cause. I come back to that later. But also if there are associated features, like if there is Parkinsonism, patients with Parkinson's can also have dystonia, so that gives a very different patient than the one who has just a focal dystonia. Or it comes with myoclonus, like with myoclonus dystonia. But you can also have like deafness, or people who have blindness, or have like liver problems. And you take that together with the dystonia, and you get this very individual patient. And then you're going to find out what is the cause, but that will help you what you can expect, what kind of cause it is. So describing the clinical features gives the individual patient, and for that you can do more focused analysis of what is the cause of the dystonia. Okay, and now I would like to tell you something about, like I said, there are two forms. You have the focal dystonia and the generalized dystonia, and most of the patients have the focal dystonia, so I would like to show you a new approach that we made about if you come to the doctor, what kind of additional investigations should be done in that individual patient. So we did that in 2022, and with a group of Dutch neurologists and a fellow that came from us from Letland. And this is actually what it is. These are the steps we take in the clinic. We first ask ourselves, is it dystonia? Because it can look like dystonia, but it's not always dystonia. So I will show you some slides to show that. Then a very important question is, can the dystonia be caused by medication? Because quite some patients who use medication, and I will come back to that in a second as well, can get dystonia due to the medication. If it's not, then you have to think about, are there acquired causes, like are there signs in the patients that guide you, especially like I told you, are there additional signs, other signs that tell you, well, it's not just dystonia, we have to see if it is something that came from like an infection or a vascular lesion. Then you have to think about, is it a neurodegenerative disorder? And then I mean like Parkinson's disease, or that I think that's the main one. And if not, then you have what we call an adult onset isolated focal dystonia. So I'm going to talk you through a few of these steps. So the first one is it dystonia? If we see a young girl with a cervical dystonia, we think this is weird. Because as I told you, cervical dystonia comes at the middle age or above 35. So if you have a 20-year-old with a cervical dystonia, we as doctors have to think about, is this dystonia? And there are quite some patients at that age, and I put a error. Thank you so much. There, as you can see there is a very thin line. And that means that this muscle here, the sternocleidomastoid, in which many of you probably get your botulinum toxin, is not a muscle, but it's a string. And that starts already at birth. And we used to think that quite some of these patients had a breech delivery, so they come upside down. And we thought that it came from pulling, but now it's thought that it's probably the case they're upside down because they have this already when they're not born. So, it's very hard to find out, but that's the thought now. And if you have that, then if you grow in puberty, that string doesn't grow with it, so then you get the abnormal posturing because it gets too short. But you should not give botulinum toxin there because it's not dystonia, but that string has to be cut and then the posture will normalize. So for us, that's a sign. It doesn't fit with the clinical. Am I doing okay here? Okay. Okay. So that helps you thinking we have to look for something else. And then we have patients like with arthritis who have abnormal posturing, but that's a bone problem. So that's not a brain problem, but a bone, as you can see here. So that it can be from a luxation or, I'm not sure, I'm moving a bit this side. Anyways, so what helps here thinking is if it is a fixed position that doesn't fit with dystonia. If there is a lot of pain, cervical dystonia especially comes with pain, but when there is a lot of pain, you have to think of something else. And when it starts acutely, that doesn't fit with dystonia. So those are clues that help you thinking about, I have to see if this is really dystonia. Then, as I said, there are quite some drugs, and I listed them here. And the most common ones are neuroleptic drugs. So on the left side, this lady used neuroleptic drugs, and the typical posturing is then that they have a bit of retrocollis and usually one hand going to the back. And that can be quite severe. And even if you stop the drugs, it doesn't get better. So that's really bad. And not all psychiatric patients can stop the medication. So she also has a sensory trick by putting something on her head. And this is a patient with an acute dystonia. Oh, can you turn on this video, please? This comes in acute phases, especially around the mouth, when patients have used drugs like cocaine. It can happen, but it can also happen with metoclopramide, which is a drug for nausea, so you don't expect it, but they get this acute dystonia. But this is treatable, and you can give an anti-drug, and then it will disappear. So you must just be aware of it, that it can happen. Okay. So then we have the other steps. I will not take you through all those steps, but at the end we come to the fact that it is a phenotype compatible with adult onset isolated dystonia. And then we have all the different forms: the cervical dystonia, blepharospasm, or mandibular dystonia, laryngeal dystonia, task specific, Mersey syndrome, where you have the eyes and also a bit of the neck, and cervical dystonia plus mandibular dystonia. And this is the temporal pattern that fits with it. And as I said, it's only dystonia, but you can have a little bit of tremor or jerky movements that are part of the dystonia. And if you have this, you actually don't need any additional investigations, because you're not gonna find anything. The only thing that we do usually check is the thyroid, as there are a few cases described with thyroid disorder that you can get dystonia. But otherwise you don't actually need MRIs or other tests, because you're probably not gonna find anything. Okay, so I told you about late onset. Now I would like to move to the generalized dystonia, and specifically about myoclonic dystonia. There is also a new genetic classification of dystonia, and that is, there are, as you might know, you have DIT1, DIT2, and that was numbered, and we are going up, I think, well, in 50 or there are a lot now, and they were just numbered by the first one that was discovered. So the torsin 1A was first discovered, so that was the DIT1 gene. But there was such a long list, and you just had to remember the names, what it means. So they decided to make a more structured classification. So they now say DIT if it is just dystonia, isolated dystonia, and then they put the gene name behind it. So ANO3 is one of the generalized dystonia genes. Then there is the combined types, which is like myoclonus and dystonia, and then you put behind the gene that is in the SGCE. It's a gene that causes this myoclonic dystonia. I will come back to that in a minute. And then you have the complex ones, which means patients have much more than dystonia. So they ordered them in that way to get more insight in what a specific patient has, and you don't have to remember the numbers. And as I said, why did we do that? If we look here, this is PubMed, that all the publications that have been published over the years. This is 1947, this is 2022, and as you can see, many papers have been published on genetics and dystonia, leading to a lot of articles, and that led to the fact that we had to organize it better, so we all know very well what we're talking about when we see a patient. And then, like I said here, one of the forms is dystonia with myoclonus, and I was asked to tell you a little bit more about myoclonic dystonia. It's rare. There are just 2 in 500,000 people who have myoclonic dystonia. But I must say, on the other hand, in the Netherlands, it's the most common form of genetic dystonia. I've seen a lot of patients with that. What are the clinical criteria? Well, it is mainly myoclonus. I will show you that in a video in a minute, but there is also dystonia, and it's almost all in the upper part of the body, but it can be in the legs, but it's mainly in the shoulders, the neck, the trunk. But it's not really truncal dystonia, so that there is a posturing of the trunk itself. There is a positive family history in most patients. It starts before 18. It usually starts at the end of primary school, so between 5 and 10. And there is an association that patients have more psychiatric problems, not all of them. And it's alcohol responsive. For a doctor, this is something to ask when patients come to the clinic. If you drink 1 or 2 drinks, the dystonia and the myoclonus get much better. And that if that has to do with the alcohol dependence, one can imagine, but well, you don't know. And in some patients, when they have limb dystonia with the leg or the arm, then that get better over time. So during childhood or adolescence, the dystonia again get better. Well, how does it look like? This is a patient who came to my clinic actually at this age. He was a farmer, and well, he did all his work, but at some point he felt that he was a bit disabled by this jerky movement and dystonia. And as you can see, there is dystonia, posturing of the arm, and also the one shoulder is higher than the other one. Can we see this video once again, please? Yeah. But what is most prominent, as you can see, is the jerky movements, mainly in his shoulders. That's what we call myoclonus. Very rapid, jerky movements. And they come spontaneously, but usually get worse with action, as you can see here as well. And this is another feature that comes in about 70% of patients, which is the writer's cramp, as you can see here. And what you can see here clearly as well, when he writes, this is another patient, the jerky movement and the dystonia get much worse. So that's what we call the overflow. When you do something, other parts of your body get more dystonia. And here again, we ask him to write with the other hand, which is very difficult for him. And again, you see the thumb going up on the other side. But this is different than what I told you about the isolated writer's cramp, because there we try botulinum toxin for the writer's cramp, but he has so many other features that the writer's cramp is not his main problem. But if we as doctors see a child with writer's cramp and some jerky movement, it's very likely to be myoclonic dystonia. And as I said, there are also non-motor symptoms. You probably have heard in the past lectures about non-motor symptoms in all sorts of dystonia that are more common, which are psychiatric features like depression. Not sure. Okay. Like depression and anxiety that come more often in dystonia patients, definitely not in all, but there is a higher prevalence. And sleep disorders and fatigue. But specifically in myoclonic dystonia, this rate is even a bit higher. And what we see in the papers is especially anxiety disorders, panic attacks. They have quite some panic attacks. There is obsessive compulsive behavior, and like I said, alcoholism. So this is really something that comes with patients with myoclonic dystonia, but not all of them, but a higher part than in the general population. And then the cause. Over the last few years we did a few studies, and what we see is that patients get their myoclonic dystonia. It gets worse over puberty till about 20-25, and then it flattens. Then it's usually not progressive anymore. We did a study on that, and we did see that was the case. But we did see that the psychiatric features did get worse, even in later adulthood. And then we did a study, and this is a lot of text, but we did a study together with Belén Perez from Barcelona, and we looked in children and adolescents, and what we did see that there is a progression of motor symptoms, and that they, especially in the axial and the limb myoclonus, as well as during writing, and they reported speech problems, walking and writing problems. And as you can see, quite a lot of the children had psychiatric problems, also including ADHD. Then about the genetics. I told you already that this is the gene, the SGCE gene, that causes myoclonic dystonia, and that's a gene that is located on chromosome 7, and it has an autosomal dominant inheritance pattern. You probably know what that means. That means that if you, this is a round one are females, the squares are males, and if it's dark, patients are, the person is affected. So if you have one affected parent, you have a 50% chance that you will get the disorder will go to your children. At least the affected gene will go to your children. You can be unlucky, 3 times affected, because it's 50% for each child. And here you see there are 2 not and 3 are affected. So it's about 50%, because you either give the affected gene to your child or you don't give it. If you don't give it, it's not a problem anymore. However, this is the general autosomal dominant inheritance pattern, but it's a bit different in myoclonic dystonia, because they have what we call reduced penetrance maternal imprinting. And what that means is that we all, from this gene, use only the part that we get from our father. So you always have all your genes double. You have one from your mom, one from your father, and usually in the autosomal dominant inheritance pattern, if you get it from your mom or your dad, there is a 50% chance. In myoclonic dystonia, you use, which is a bit of a weird word to use, but I think it's the most clearest way to say it. We all use the allele that we get from our father. And that means that if you get the affected allele from your mother, you are a carrier, so you have an affected allele, but you have no problems. But you can give it to your children. So what happens, as you can see here, there is a mom who is affected because she get it from her father. Then she has a lot of children, none affected. But there are some dots in here, which mean that she did give the affected allele to her children, but they have no problems because they use the one they got from their father. And then there is this female again who gives it to her children, and he is affected, he's carrying the gene, and now we have a man giving it to a child, and then the child does show symptoms. So you have these pedigrees of families. It shows that it's the single one, but if you really dig into the family, there is someone coming from. And if you look at the genetic information of these, his father is a carrier, but doesn't have the symptoms. And there you see it again, that there is, and there is no information of the older family, but here it comes from the father and is affected. Here is a mom affected, but no children affected. And again, if it comes from the father, then you have the symptoms. So this is complicated, and this is not common. This is just one of the few disorders that we know that it runs this way. No genotype-phenotype association. That means in the gene for myoclonic dystonia, you can have different changes. But it doesn't mean that if you have a certain change, that you know how severe it will be. And we know that because within a family, patients can have very mild symptoms and very severe symptoms, but carrying the same mutation. So you cannot say if you have that mutation it will be okay, and you have that mutation you will have severe symptoms, because we don't know. And if we look at patients with myoclonic dystonia and we check them the genetics, we find in about 50% of the patients a mutation in this gene. So there is another 50% of patients who have the same clinical features but have no mutation in the gene. And as I told you, we have a lot of publication and a lot of knowledge now, more knowledge, we still don't know everything. And then we found out that there are 5 more genes. If you have a change in that gene, you can also get myoclonic dystonia. So you have similar as patients who have the epsilon sarcoglycan gene, the top one, but the other ones can give the same clinical phenotype, so the same picture in a patient. And there will probably become more over time. Then about therapy, it's hard to treat patients with myoclonic dystonia with medication. It's usually not very effective. There are some drugs, clonazepam, trihexyphenidyl and zonisamide. With zonisamide there has been a study done by Emmanuel Rose in Paris that it was effective. But I must say in clinical practice there are a lot of patients who are having psychiatric side effects when they use it. So I'm a bit reluctant to prescribe it. GHB, that we know for other reasons, I have no experience with it, but there is some literature that it can be effective, but it has other problems. You can give botulinum toxin, especially for the neck dystonia, similar to the focal dystonia and adult onset dystonia. And the patient who was online, Salvatore, he told already that he had DBS. And I think for myoclonic dystonia, if you have a severe form, it's one of the most effective patient group to give DBS. 70 to 90% improvement in myoclonus, 60 to 80% improvement in dystonia. But again, not in every patient, so you must always be cautious with what you predict. But in general, this is a group of patients that we should offer DBS because it's usually quite effective. Okay, so then I come to the end of my presentation. I told you a bit about dystonia, lots of things you know already, about the new classification of dystonia, the novel diagnostic approach. I think is very helpful in the clinic and also limits the amount of additional investigations that we have to do. And I told you a bit about myoclonic dystonia. Thank you very much for your attention.
Closer. This. Okay. Yeah. Okay. So I want to thank you for that, Professor, and for actually being really calm when things were going on with with the laptop. But and thank you for bringing it all to life as well with the videos. I really enjoyed those as well. That's really helpful to understand it. We will do Q&A after the next presentation, so I'll bring you back up here if that's okay.
Yes, sure.
And I'll let you go and sit down. Okay. So we mentioned as well, and you mentioned a lot about deep brain stimulation, DBS, and that leads us in a perfect segue to our next video. I think the next speaker is joining live, I believe, are they? Is it via Zoom they're joining? Okay. So I am going to welcome live via Zoom Dr. Jonathan Ellenbogen. I don't know if Dr. Ellenbogen is actually online right now. Can you hear us? If he can hear us at all?
I can. Can you hear me?
Whilst you're doing that, I'll introduce you, Dr. Ellenbogen. You actually come from, well, you come from near where I live in Manchester, and you're going to talk to us, I believe, about the understanding of DBS in dystonia. So a nice segue from the previous speaker.
Yeah, hopefully.
Okay.
Can you hear me okay?
I can hear you loud and clear, absolutely.
Great, and you can see my slides on slideshow.
We can see your slides.
Great.
Well,
Okay.
yes,
Well,
we can.
I shall begin. I just want to thank Dystonia Europe for the very kind invitation to come and talk to you. It's an honour and a privilege to be here. I'm sorry I can't be there in person. It's school holidays, unfortunately, so family demands take precedent, I'm afraid. But I'm glad that I can be here virtually to talk to you about DBS. So I'm going to talk to you about why we consider surgical treatments in dystonia, what is deep brain stimulation and how it works, and we're going to discuss how you assess the suitability for patients for deep brain stimulation and the outcomes and where the future lies. So I think it's important to understand that that dystonia is a disorder of movement and also a disorder of tone. And it's important that we understand what we're actually discussing and treating if we're going to start to discuss surgical management. And why is this important? Well, the management of movement disorders very much depends on what the underlying movement disorder is. And there's a lot of crossover between dystonia and spasticity. But I think the key is that dystonia is something that you see and spasticity is something that you feel. This is important because, particularly in children, I am a functional neurosurgeon that works with adults and children. You will see in children, particularly, that dystonia rarely presents as a pure movement disorder, but alone. It often presents with spasticity or with other movement disorders, and therefore it's key for us to try and tease out what the underlying or predominant movement disorder is, so we can offer the appropriate treatment for that. Because dystonia itself has a range of mechanisms in its pathophysiology, in the way it develops. In younger people, it tends to be genetic, and older people with susceptible genes, there's environmental influences also. Different circuits within the brain are affected, and this results in different functional consequences for the brain. When you're younger, you have more plasticity, the brain is able to adapt and change, and less so as you get older. But at the end of the day, what it results in is this overflow of opposite muscles, which results in dystonia. And it's important that we understand that because of what we're treating. When we're talking about deep brain stimulation for dystonia, we're acting on the brain itself. Another modality we can use for dystonia is intrathecal baclofen, and that works on the spinal cord. But if we're talking about spasticity, it's a completely different operation that we would do to reduce spasticity. So it's really key for us to understand what the predominant movement disorder is. In children, secondary dystonia is much more common than primary dystonia. And when I talk about primary dystonia, I mean genetic causes of dystonia. So cerebral palsy is relatively commoner cause of dystonia in children. And about 7% of those children born with cerebral palsy will have dyskinesia. And this is often misdiagnosed in the community as spasticity, and this is why it's important. As you've heard already, adult dystonias are generally focal and affecting more specific body areas such as cervical dystonia, blepharospasm, and then you've got the more task-specific dystonias, as was mentioned earlier. And why do we consider treating dystonia? Well, I'm sure you all know it interferes with function, positioning, comfort, sleep, care, but actually the most important thing is it can negatively affect quality of life. In children, particularly when you have this early in life, you get this combination of skeletal muscle shortening because of lack of use. You end up with fixed contractures, joint instability, which results in pain. And pain is a huge driver for dystonia, which makes everything a lot worse. And you get into this cycle of increasing pain, increasing dystonia, increasing muscle spasm, and therefore it's difficult to get out of this pathway. And in children, we can particularly see that those children with dystonia, particularly secondary dystonias, develop these fixed muscle contractions or deformities much quicker than those with primary dystonia. So it's key that we get these children treated early in life to prevent this fixed muscle deformity, which will result in pain and worsening of their symptoms. And the problem with medication is that there's little evidence from any controlled trials on the best therapeutic strategies. And there's a general consensus that they're not very efficacious, most medications. The ones that are tried have significant side effect profiles. And if you're using lots of benzodiazepines, they can develop tolerance or dependence with this. And the key really is there's no consensus definition of drug resistance. When we talk about epilepsy or surgical management of epilepsy, we often refer to a failure of 2 drugs to control epilepsy. But when we talk about movement disorders, there isn't really that understanding of when we've tried enough medication to try surgical barriers, surgical methods. And I think this is a problem of understanding generally to try and get people into assessment for neurosurgical interventions earlier, which might benefit from it. So surgical treatment of dystonia is required because it's an unremitting and often progressive disorder. Symptoms can become more generalized with time, with leading to increased disability. It can lead to life-threatening conditions. There's no effective medical therapy, as we've just discussed, and there's possible significant improvements in quality of life that can be offered with deep brain stimulation. And when we talk about deep brain stimulation, as I alluded to earlier, when we talk about dystonia, we can treat it with DBS or intrathecal baclofen, are the mainstays of treatment for dystonia. But DBS, you'll see from this little chart here, really is in that sweet spot of being a reversible treatment because we're not destroying any tissue within the brain, and also works for more generalized and focal dystonias. So it is often the treatment of choice for those people who are considering neurosurgical interventions for dystonia. And where does it come from? Well, it originally originates from destructive surgery. So there used to be a vogue many years ago for doing destructive lesionings of the brain to try and improve movement disorders, which is coming back to a certain extent now again. But that's where the original understanding of the ability to modulate the brain to improve movement disorders originated from. And it came from further improvements in those patients with Parkinson's disease, which was the mainstay of original treatment. And the first child was implanted with a deep brain stimulator in 1996. So this isn't a new technology. It's been developed over many years. And this is just to give you an idea of that development. Since really the 1940s onwards, this technology has slowly developed over time. Originally with the development of stereotactic neurosurgery, so the ability to very accurately implant things into the brain in a very accurate and controlled and precise way, with the development of a lead cell frame back in 1949, to the first fully implantable deep brain stimulator in the 1980s, to rechargeable batteries in 2009, and now more recently the ability to offer steering of the current and MRI compatibility. So deep brain stimulation consists of an electrode which is implanted into a deep structure of the brain. When we talk about dystonia, we often talk about the globus pallidus internus, which is this section here, but we also can use the subthalamic nucleus. Those electrodes are implanted very accurately into those structures, which are very small, and then those wires are fed out, usually behind the ear, to an extension cable, which runs down into the IPG, or the implantable pulse generator or battery that sits in the chest. And at the moment, we have 2 types of battery: a primary cell battery, which is a fixed life battery, and a rechargeable battery. Now, the benefit of a primary cell battery is that it stays there and nothing needs to be changed for 3 to 5 years when the battery depletes and you need another small operation to change the battery. But it is larger in size, and you do need to have a surgery every 3 to 5 years to change that battery. But you don't need to recharge it. There's nothing you need to do in that intervening period, so you forget about it. There's nothing you need to do. The rechargeable battery, on the other hand, is much smaller, thinner, and will last in the region of at least 15 years before you need to have further surgery. But the downside of that is that it needs recharging, much like a mobile phone that you might place on a pad to recharge it. It's very similar. You get a pad that fits over the battery and recharges through the skin. But you need to remember to recharge it. And in terms of the electrodes in the brain, what we started with is on the left, which is a standard lead, which was a rings of metal contacts around the lead, which we could stimulate at different levels. Now we have directional leads, so those contacts are broken up, and so they're no longer a ring, they're 3 segments around that ring, and each of those segments can be stimulated as we like it to be, to try and steer the current to maximize the benefit and minimize the side effects for the patient. When we're talking about implanting into the brain, into the deep structures, this is the globus pallidus internus, this structure here. It's not very easily seen on this image, but you can make it out here and on here. But in deep brain stimulation, the targets are always growing because we're using it to treat different pathologies all the time. So the targets are growing depending on what we're treating. So this is a technology that's being used more and more for different disorders through the brain. And how does it work? The truth is, nobody really knows how it works. We're applying electrical signals to the area, to a very focal area of the brain, and we're hoping that those signals alter the local milieu around those cells, but also affect and change the way that the fibers that are going through those areas are also acting. So it has distant effects away from the area that we're stimulating. So it's a combination of affecting the local cells in that area, but also the tracts that lead to other areas of the brain, and altering and modulating those tracts and how those neurons are firing, which over time results in improvements in dystonia. And what you'll see, you may all have seen videos of people with Parkinson's disease who have deep brain stimulators suddenly switched on and their movement disorder gets better. But that doesn't happen in dystonia. It sometimes takes weeks, months, or even longer for us to see effects in improvements in dystonia. It's because lots of these downstream modulatory effects of deep brain stimulation need to occur before we see a response in dystonia. Fewer of them occur in tremor or Parkinson's disease, but lots of these things need to occur because it's a much more widespread disorder of the brain, dystonia, as I mentioned in the first few slides. Therefore, it takes a long time often after a deep brain stimulator has gone in before we see positive results. And this is the reason why. How do we select the right patients for deep brain stimulator? Well, usually they're patients who are refractory to medical therapy, and as we've said, medication doesn't really work very well for many people. The symptoms are severe enough to produce disability and affect quality of life, and also pain. We know that deep brain stimulation actually works very well for those patients who have significant amounts of pain with dystonia. But there are no validated criteria for DBS, particularly in children. There is no specific cut-off related to symptom severity. And in Parkinson's disease, we have various challenges that we can use to help us understand whether the deep brain stimulation will work for that patient, but it's not the same in dystonia. We don't have any predictors which help us understand whether this intervention, this device will work for the patient. But there are some factors which suggest a better outcome with deep brain stimulation. Those patients with defined gene mutations, those patients who've had dystonia for a short length of time, those with minimal skeletal deformities, and those with minimal weakness and spasticity. But it really takes a big team to understand what patients might benefit, which patients might benefit, and for which patients it's the right intervention to use. So we have a huge MDT team which makes these decisions about the appropriateness of patients for deep brain stimulation. And it's important because we need to select and assess the right candidates. What's very key for dystonia, I feel, is identifying reasonable outcome goals for treatment for the patient, for the child, for the family. Because in dystonia, a lot of the grading scales, as I'll come on to later, aren't very accurate, aren't very good for assessing actual outcomes and what's important for a patient. And I think what's really important is that the goals that the patient has are realistic and attainable. And I think that's the key for DBS treatment in dystonia. We need the team to help us to optimize the stimulation parameters to gain the best effects, to support patients and families, and to help cope with any complications that arise from the therapy or the devices. Remember, this is a surgical intervention. There are risks and complications with it. This is the tone management pathway in Alder Hey, which is my predominant base, which is a children's hospital in Liverpool. And any patient that referred in from the community goes initially for an assessment to understand what their underlying movement disorder is, what their predominant disorder is. As you remember, as I said at the start, a lot of these children are referred in for one treatment or another, but the referrer doesn't necessarily understand the full movement disorder. So it's important for us to understand what the underlying movement disorder is so we can offer the right treatment. And I just wanted to show you some videos of the positive effects that DBS can have. This is a child with significant dystonia, has difficulty standing, has difficulty getting themselves from a mat to a sitting position. The volumes obviously you can't hear, but he's quite distressed trying to do this and quite upset with the idea of trying to do this, getting onto a seat. And if I move on, this is after deep brain stimulation has gone in. Now, this isn't attainable for everybody, but it's just an example of the positive benefit that DBS can offer to certain patients, which isn't often seen. Well, what are the difficulties in children as compared to adults when you're deciding whether a patient should have deep brain stimulation? Well, there's a degree, as we all know, about the effectiveness of deep brain stimulation, particularly in acquired forms. In genetic forms, we know the responses are generically very good, but in acquired and cerebral palsy type dystonias, there is a degree of uncertainty about how effective the therapy will be. And obviously, it's a lifelong commitment to continue stimulation. And therefore, a parent often has to give consent on the behalf of a child because they may not have capacity to make that decision. And that triad of the patient, the caregivers, and clinicians adds additional complexity to any decision making when it comes to deep brain stimulation. In an adult interaction, it makes it much more simpler for those adults that have got capacity to consent. But when we're talking about children, a lot of them don't have that capacity. And a parent's decision to have deep brain stimulation may have a domino effect on their subsequent choices later in life. So it is something important to consider. The important thing is to give as much information as the family wants to know. Some families don't want to know all the ins and outs and are happy to proceed on that basis. And others want to know everything they can. And it's important that you tailor the information to that family. And as I said earlier, defining specific and realistic goals are really important. And often giving patients the contact details of patients who've already had DBS implants in so they understand what it involves is important. Demonstrate the implants and give patients time. Now, how do we implant the deep brain stimulator? Well, it's based on stereotactic neurosurgery, as I said earlier. Now, there are lots of different ways and methods of implanting the electrodes very accurately into the brain, but that's the key. It needs to be implanted very accurately and precisely because the areas that we're targeting are extremely small. I use a robot in my practice. This is an example of a head frame which holds the head still for the operation. You can imagine if we're implanting something very precisely into the brain, the head needs to be held very securely in position so it doesn't move. It's a little bit medieval, this device, but it basically has 4 screws that go into the skull and hold it very firmly in position during the operation. This frame I use is a CRW frame, and it's beneficial because it has a reducer which reduces the size of it, allowing me to get very small children's heads into it as well. This is how it looks. The head is fixed into the robot, and then what I do is bring the robot arm very close to the head and perform a CT or an O-arm scan in theatre, which registers the position of the robot to the head, so it knows exactly where the head is in three-dimensional space, and then can lead me to the right trajectory and depth that I've planned pre-operatively on the MRI scans. This is just an example of the setup. And just to show you how precisely it can get, the green star is the target that I had planned pre-operatively, and the white overlay is the actual implant within the brain. So it's a very accurate and precise way of delivering the electrodes. And this is what it looks like on an X-ray. You can see the DBS electrodes going into the brain. They're tunneled out behind the ear to extension cables, which then run down under the skin. Everything's internal. You don't see any of this to a battery. Now, in adults, we often implant just on the chest, just below the clavicle, on the left or the right-hand side. In children, we often implant in the abdomen. And the reason for that is that children are often with generalized dystonias are moving a lot. They have a lot of energy expenditure, meaning they don't have a lot of subcutaneous fat, and therefore there isn't a lot of skin sometimes in the chest in which to implant the battery and stop erosion of the battery through the skin. And sometimes it's easier to implant in the abdomen to prevent that from happening. The difficulties in programming, particularly in children, are often these children are non-communicative, or they have intellectual disabilities, and they have multiple comorbidities such as orthopedic issues and pain, meaning sometimes it's very difficult and time-consuming to get the programming right to get the maximum benefit for these children. Now, there are, as I said earlier, the electrodes have moved on in terms of their development over time, and we started on the far left with 4 ring contacts, and we've moved gradually towards the right-hand side of this with the ability to offer directional stimulation. We can offer unipolar stimulation, which is stimulating one contact on an electrode with the battery being the other contact. A bipolar stimulation, which is stimulating between 2 electrodes on the same lead. We can offer multiple level and directional stimulation. So all these things help us to maximize benefit and minimize side effects. Now you might say, well, how do you know, particularly in children or in people, that you're having difficulty in programming, that you know where the electrode is? Well, what we can do is use a program like this, which implants a the electrode virtually into the brain, which has been segmented out. And what you can see in orange there is the GPI. This is the target for this electrode. And we can put a stimulation into this program of a certain number of milliamps or whatever frequency, and it gives us an estimation of the area that we're stimulating. And we can see that stimulation overlaid onto a map of the brain of the target that we're stimulating. So we can see exactly where we're stimulating. Now, it's not 100% accurate, but in those patients that we're finding it difficult to program, or that we just like the idea of knowing where the electrode is and where the stimulation field is, we can use this from the beginning to try and maximize the benefit from the patient from the word go, because then we've got a visual idea of where we're stimulating within the brain compared to our actual target. Now, now we're going to come to outcomes and how do we describe these outcomes. Well, in children that's more difficult because children undergo neurodevelopmental progress as they grow up. They often have additional neurological comorbidities which affect their quality of life. Some of them have intellectual disabilities, and therefore they require cognitive assessment. But actually, I think the ideal rating scale for dystonia full stop is personalized, realistic goals from the therapy. We have lots of scales that help us understand the impact of dystonia, but none of these really truly reflect what's important for the patient and or for their family. And I think what we all need to understand as clinicians is that every patient has their own goals from the therapy, and we need to make sure that we tailor our outcomes or offer realistic goals for the patients, which are attainable. This is just a review looking at the motor scale improvement for deep brain stimulation dystonia for those children with cerebral palsy, and a negative result is basically an improvement. And what you can see here, that generally across the scale, deep brain stimulation for dystonia, even in cerebral palsy, shows a great positive effect. So where does the future lie? Well, I think when we're talking about deep brain stimulation, I think we are moving towards personalized, adaptive, circuit level control of the motor networks. And I'll explain what I mean by that. At the moment, we have something called brain sense technology on certain manufacturers, and that is a way of not only stimulating down the electrode, but we can also understand the electrical activity around those contacts and get information back from the brain. And this is called local field potentials, or the local electrical activity around the electrodes. So not only can we stimulate down, but we can get information back from the brain once the electrodes are in it. And what you'll see here on the top graph is the local field potential, the LFP. And you can see it's very variable, up and down, up and down, up and down. But as we increase the amplitude of stimulation, we can see that this electrical waveform becomes much. And we think that if we can get this waveform, we are causing an improvement in the patient's dystonia, and therefore we can find out what is the maximum benefit from the patient just looking at the local field potentials, not even being able to look at the patient. We're not quite there yet, but we're getting to that stage. And this is the reason why there is some oscillations of different frequencies of different electrical activity within the brain, which corresponds to different movement disorders, we think. So in Parkinson's disease, we talk about the beta frequency, but in dystonia, we're talking about these lower frequencies, around 20 hertz or lower, which show a positive effect with those patients who have significant dystonia, have a lot of electrical activity in this frequency. Which is down here on this frequency curve, you can see here. And this is what we get, this is the sort of output that we can get looking at the different frequencies over time between the left and the right hemisphere this is when a patient's irritable. And we can get event markers, so we can ask the patients to event mark when their dystonia is particularly bad, for example, and then look back at the electrical activity at that point in time to personalize and review the local field potentials to see if we can offer stimulation that will tackle those particular points in time. And we get these power spectrum which enable us to look at the brain, see what's going on, and therefore hopefully offer a change in the stimulation value to improve this. And over time, I'm hopeful that we'll get to a stage where we have a closed loop or adaptive deep brain stimulation. At the moment, what happens is that we offer a constant stimulation over time. But for Parkinson's disease, we've recently launched, adaptive DBS, where the brain senses the activity of what's going on in the brain and alters the stimulation of the deep brain stimulator depending on the activity of the brain. And I'm hopeful in the next few years that this will be offered for dystonia as well. At the moment, you come in for a programming session, the stimulation is changed, you go away, you see if the dystonia improves, you go back and have another programming session. But what would be ideal is if we took the need to come back to see a clinician out of this. We have a stimulator which offers a stimulator. We have a sensor already in the brain. It understands what's going on depending on the electrical activity of the brain. It alters the stimulation and then changes the stimulation to the benefit of the patient without on a minute-by-minute basis, ideally. And this is where AI is coming into this. We're hoping that and it's starting to be used to help identify biomarkers of dystonia. What are the key things that we need to be looking at within the brain for dystonia, and helping to predict DBS responders. It hopefully will optimize the stimulation settings automatically. As I alluded to earlier, if we can understand what's going on in the brain, AI can help understand and change the modulation as and when it happens. Now, hopefully we'll get to a point where it detects symptom fluctuations and we'll have wearables that will be able to understand what the movement disorder is at that time to help alter the programming. And hopefully over time, programming sessions that currently take many hours might become largely automated. And this is just to give you an example of the number of studies ongoing that have happened at the moment within neuromodulation, looking at AI and the different types of AI that have been used. So this is a huge huge number of studies at the moment looking at AI and how that can be integrated into movement disorder and deep brain stimulation practice. We're also moving into a field of higher field MRIs. At the moment, most of the targeting is done on a 1.5 or a 3 Tesla MRI, which has very good resolution, but 7 Tesla has even better resolution. And at the moment, on the left, you'll see a diagram looking at the GPI, and on the right at the top, you can see a 3T scan, and on the bottom, a 7 Tesla scan. And you can see the improvements in resolution that can be offered through 7 Tesla. And there are some number of studies going on at the moment looking at whether having higher field MRI scans giving you better resolution helps with targeting for the electrodes. And I'm hopeful moving forward, as imaging improves all the time, instead of looking at single targets such as the GPIs or the STN, we'll have resting functional MRI, which you can see on the top there, or structural connectivity such as diffusion tensor imaging, which looks at the individual functioning of the brain for each person and understands where dysfunctional circuit is in that particular patient. And if we understand where the circuit is, maybe we can offer different targets for different people to maximize the benefit going forwards. Because at the end of the day, this is a network problem rather than a single area of the brain that has an issue. And therefore, if we can find the relevant tracks that are involved, we can maybe stimulate those tracks rather than a single area of target to offer improved benefits. We already have remote programming, so certain manufacturers offer programming that can be done from the other side of the world. So a clinician can be sat in their office and the patient can, for example, could be in Australia and they can program remotely through the internet. And I think what we have currently is on the left-hand side of this diagram. On the right, the future might look something like this with much smaller cranialized batteries, so reducing the amount of wiring that's required. There is development going on for cranial-based batteries, so everything is on the skull and smaller, and hopefully we will get to a point where we can offer that, reducing the need for all the extra wiring and the large batteries sitting in the chest or the abdomen. And there are advances all the time. Now, the advances the nice thing about being involved in this type of surgery is that the advances are occurring all the time. This is at the forefront of development of neural interface, and I think that because of this, there's always developments going on. So not only in miniaturization, but also in battery technology and the size of them, with also increased safety with 3 Tesla MRI systems. Hopefully antibiotic impregnation will help to reduce infection over time. We can change the stimulation parameters, and as I said earlier about adaptive and closed loop stimulation is hopefully going to be the future for dystonia, and advances in also in neuroimaging to find the sweet spots within the brain which may yet to be elucidated. So over time, I'm hoping that we'll be able to record the pathological brain rhythms continuously, which we can do already with brain sensing. but also detect when those dystonic movements are emerging. So maybe we're having wearables such as a watch that can feed back, or some other wearable device that can feed back when the movement disorder is particularly bad. Delivering stimulation only when needed by using AI pattern recognition, and reducing side effects and battery use by using adaptive stimulation. So offering a personalized therapy minute by minute rather than a periodic clinic-based programming session. But there are some still unresolved challenges within dystonia, in that dystonia is biologically heterogeneous. So there's lots of different underlying pathways and mechanisms in dystonia, so it may not be a one-size-fits-all. The reliable biomarkers are still limited. We're still not 100% sure what we're looking at in terms of the brain LFPs in understanding dystonia. The brain networks, as I said earlier, vary widely between patients which are abnormal, and the long-term plasticity effects are completely understood. And the future depends really on decoding these abnormal brain states in real time, thereby shifting from static stimulation to intelligent neural regulation or neuromodulation. And I'd just like to finish on this little study that I performed in the UK with some colleagues. I think the biggest barrier to surgical intervention with dystonia, particularly in the UK, is the lack of referrals and the lack of understanding of the option of neurosurgical intervention for dystonia. Particularly in the UK, I think a barrier is the understanding that there is the service and what should be referred in and which patients shouldn't be referred in. For example, in my clinic only last week, I saw the younger brother of a patient that I had treated as an adult, and the adult sibling and family were very upset that they had to wait till they became an adult to have treatment, and they didn't know that the treatment was available for them as a child. And so their younger brother has been sent to me for the same treatment now, and they would have had that for the older child if they'd known about it. So we did a Delphi consensus looking at lots of areas of the country that were involved with pediatric movement disorders, and to get referral criteria to understand which children should be referred in for DBS therapy, or assessment at least, for different movement disorders, with the aim of trying to improve the referral basis of these patients that sit in the community a lot of the time and don't know about the surgical management or ability to have surgical intervention for their disorder. So in conclusion, DBS is an important part of the armamentarium for the management of dystonia and can have a huge impact on quality of life. And the technology is constantly evolving and improving, and with it we hope the outcomes for our patients.
Thank you, Dr. Ellenbogen, for that. That was brilliant. Are you able to stay on?
Yes, yeah.
Yeah, for about 10 to 15 minutes. And if I can ask Professor de Koning to come up as well, and we can take some questions and answers from the audience now. We will be breaking at 1/4 the hour, but we do have some time, and we do have a roving microphone as well going around. Or maybe just speak into the microphone. Yeah? Okay. Yeah. Yeah.
Any questions? Was it all clear?
Any questions at all? Can I start off with one then? Sure. Yeah, and I don't want any feedback with this mic, but you know that you said there was concurrently a lot of psychiatric presentations with people with, it was myoclonic dystonia, wasn't it? Is that a part of the phenotype and the syndrome, like chicken and egg, right? Which starts first, or is that worsened because of the condition that they have?
Yeah, that's a very good question, and that, to be very honest, we still didn't solve it, but we have now arguments to say that it's part of the disorder, and reasons for that is that it's well, like I showed you, there are different kind of dystonias with more different kind of psychiatry, so it sort of comes together with certain types, but also You can imagine that if you have dystonia and especially what Salvatore said, people see you, you're ashamed, and then you develop more easily psychiatric problems. But we have seen in patients that the psychiatric problems are there already before the dystonia comes, so that's an argument that that's not the case. And also, for example, they did a study comparing patients with dystonia with people with women who are bald and are ashamed of that as well, and then you also see that there is a clear difference. So sort of like the exposure to the society is not the only explanation, but it remains difficult because dystonia is still a rare disorder, so we don't have huge cohorts of patients that we can study. But there are quite some arguments now that we do consider it part of the phenotype, so part of the disorder. Yeah.
Thank you.
Hi, my question's for Dr. Ellenbogen. You said quite near the beginning of your presentation that the multidisciplinary team who decide on selection of patients for dystonia, there was a psychiatrist and a psychologist on the team. And I would really like to understand why.
Okay, good question. So there can be patients who have underlying issues. Well, the first thing to say is that undergoing this surgery is a big deal for lots of patients. So it's often useful for a neuropsychologist to be involved to help patients make the decision to go forwards with surgery, because the decision itself can be quite a difficult one to navigate, particularly in children, for example, and therefore a neuropsychologist can help patients come to terms with that. But also some of these patients, as we've just discussed, have psychiatric conditions which may be negatively affected by deep brain stimulation, because remember there are side effects from stimulation itself. So we need to understand the baseline psychological psychological understanding, so we can make sure that we're doing this not only for the right reasons for the right patients, but also that we're not going to have a negative effect on the patient from doing a deep brain stimulation.
Can I add there something to that? I think it's, well, we usually also do a neuropsychological investigation, and we studied whether that changed after DBS, and it didn't. But we still do it because sometimes patients experience after surgery that there might be some cognitive problems, and then we can redo it and assure them that it's not the case, because it looks like patients are okay. It is the impact that can give, and the psychiatric part, even though you, as I said, there are patients who have psychiatric problems, like have had a depression or anxiety. But the main thing is that at the moment of surgery, it must be stable and okay. So, but patients who have had major problems in the past are the ones you have to keep an eye on, especially after surgery. So it's not a contraindication in general, but it must be stable for a period once you consider surgery. So that's why it's important that the psychiatrist is involved, and also to know which patients are at risk. But the cognition, it seems to be not be influenced by the surgery. So, but it can be helpful, like was said, that they can support you in the whole procedure. Yeah.
Anybody else at all?
I think this is for you, Jonathan. I was thinking about development and research on non-invasive DBS, because for a lot of people it can be scary to have brain surgery and something implanted in your brain. So is there anything like that happening?
Yeah, so I was going to put a slide on that in my presentation, but I took it out at the last minute. There isn't a non-invasive deep brain stimulation, but For those patients who are wary about brain surgery per se, or implants in the brain, people are at the moment looking at studies using MRI-guided ultrasound as a lesioning technique. This is using MRI in a very using focused beams of ultrasound within an MRI scanner to target one area of the brain and heat that area up and therefore destroy it. It's back to lesioning in a way, because what we're doing is causing a lesioning within the brain, but we're doing it in a non-invasive way. So there's no surgery involved necessarily, but they're using multiple ultrasound generators targeted around the brain to all focus on one area to heat that up in real time and in an MRI scanner, so you can see the damage that you're creating in real time to help with movement disorders. It's been used in cervical dystonia in Japan, and it is in development as well in other. It's been widely used for other things, but it's starting to be used for dystonia as well to create a lesion within the brain.
Yeah, it's especially used in essential tremor patients, and well, there's always a bit of worry in dystonia if you do the bilateral globus pallidus lesioning, but there have been now some papers published showing that it looks okay, but we have always been reluctant to make bilateral lesioning. That's why we prefer the stimulation, but we have to see future studies how it works out. But because there is a bit of worry about when you have bilateral lesioning that you have speech problems and balance problems. But well, it has been done, but mainly in very severe dystonia cases where there was nothing left to do, like children who are really disabled and we had nothing else. So we are always a bit reluctant. So yeah, we have to see how it develops. But it's a nice way because it's not invasive, but well, but you do make a lesion, so that's a bit of a...
Yeah, it's destructive.
Yeah.
Any more at all? Yep, lady just at the back in the white.
Is there any experience with transcranial stimulation?
Yeah. There is some, but that has mainly been... Do you hear me or not? Yeah. Well, that has mainly been done in research settings, mainly in London by John Rothwell, who did repetitive stimulation with effect, but temporary effect. I'm not sure if there are recent studies going on, but it's always something that is going on with repetitive stimulation. So I'm not totally sure. I always have the worry that it's very temporary, so very intensive if you have to have that treatment in a very frequent way. But it does fit with the idea of dystonia, that there is changing in plasticity that you try to reset with transcranial stimulation. There are definitely studies going on, but there is I haven't heard of a solution yet in that area. Yeah.
For you, Marina, you showed a slide with the papers, 1947, and then how it is today, and that was especially about genes.
Yeah.
How would you say that the amount of research that is taking place within the field of dystonia is today compared to for 20 years ago when I first met you?
Well, that's a tough question. I mean, I can definitely say it increased a lot, but
That's what I want to hear.
I know, and it's true. But on the other hand, I think these days, because many papers are now not in paper but online, there are many papers anyway in every field, and it's not always good. But that's more like Salvatore said, a philosophical question. Yeah, there is a lot going on. I mean, especially with the DBS, with the closed loop. That's from the last 5 to 10 years that it's coming. I think that's very promising because the DBS has been for a long time had very little progression in development, but now with this closed loop I think we're really going to make steps, although it's not so easy yet. I mean, with Parkinson's disease we record and we have like what we call the beta band that reflects the clinical severity of dystonia with the local field potential recordings. But in dystonia it's not so clear. We do see a certain band and we do see it improves with DBS, but we don't see that the improvement of that band for dystonia reflects the clinical improvement, and that's what you want. So it's not so easy yet, but I think it's very promising and it's the way to go. And the genetics, there is a lot of development as well, yeah. And new botulinum toxin names, so yeah, there are things going on and many more papers, Monica, but yeah.
So, but hopeful for the community.
Absolutely, yeah. I think absolutely, absolutely, and yeah, and I think there is a big group of neurologists very interested in dystonia and neurosurgeons interested in dystonia, and I think this development in being more multidisciplinary, there are much more physiotherapists now involved. I think that's also a big step we have made over the last years. So, yeah, I think there are many things going on, definitely, but it's going not okay. I keep it there.
I think we've got one final question, Jill over there.
Yeah.
Yeah. Hi. This is a question that has been submitted online. Somebody, it must be watching the live view. Well, I hope there's lots of people watching it. But this person has submitted a question, so I'll just read it out. It is, the DBS doctor mentioned GI issues in children. This currently is our biggest issue. Parents are posting about it in childhood dystonia. We have found out about a recent classification called GI dystonia. If that is present, how effective would DBS be, and would a gastroenterologist be part of the multidisciplinary team?
I'm not sure what GI dystonia. Do you know what GI dystonia?
I think it's gastrointestinal.
Yeah, gastrointestinal. A lot of the children, or some of the children with severe generalized dystonias, present also with abdominal, what's called GI dystonia, or the abdominal dystonia, which is the gastrointestinal tract also has dystonia as well, which makes it very difficult for them to. They have vomiting or lots of constipation, diarrhea. They have lots of changes within the bowel all the time. Now, I have seen benefits with deep brain stimulation with that, but it's not guaranteed. So it's not something that we would necessarily implant the DBS with for if that was the only symptom. But most of the time this is involved with children with severe generalized dystonias, and it can have a benefit from deep brain stimulation, but there's no guarantee of that. So it's something to consider, but as an isolated dystonia, I'm not sure I've heard of it specifically.
No.
Okay.
Sorry, can I ask one more? Yeah, thank you. This has also come through online, and this person says, I would like to know what the most common side effects are in pediatric patients implanted with DBS.
Most common side effects. Okay, it depends what we're talking about. If we're talking about risk of complications, the biggest risk of complication in children actually is infection from the device. For some reason, the infection rate with children is higher than it is in adults, and nobody's really sure why that is. But that's the biggest risk with deep brain stimulation in children, is that the device gets an infection, and that can sometimes be very difficult to treat, often requiring IV antibiotics or antibiotics into the vein for several weeks, sometimes months. Sometimes part of the system needs to be removed or all of it. That's very rare that that's required, but it can happen. There are lots of different complications that can arise because this is brain surgery at the end of the day. But actually, the side effects are generally quite minimal with stimulation itself because we can modulate and change the stimulation. So if a side effect does happen, we can mitigate for it. We can change the stimulation parameters to reduce those side effects. But there are lots of possible complications with brain surgery, but the risks overall are quite small.
Thank you.
I'm just wondering, Monica and Jill, is there any way that when we get these questions in, that we're not going to cover them all in the Q&A, that we can collate them and maybe respond to them at a later date, that we can do that? Perfect. Okay. And with that, thank you to our speakers, to both of you. Thank you so much, and for the dialogue just before. And as I say, we will collect those any residual questions as well. We're now going to break for coffee. We're going to be back at quarter to where are we? 11:45. I'm an hour behind you because I'm in UK time. We're going to be back at 11:45, where we're going to continue conversations about support and therapy. Thank you.
Gott, på det filmen Og Leila, kan du lige prøve at beskrive lidt, hvordan... Og Leila, kan du... Så det gør... Prøv en gang.
du skal ikke langt nede, men altså hvis du stikker i midten. Du skal ikke langt nede, men altså hvis du stikker i midten af transfuseren, ikke, så kommer du op forbi arterien og venen. Så du skal ikke langt ned i hvert fald.
Er du klar, Grete?
Ja.
Jeg går lige i midten her. Der kommer et stykke nu.
Det er godt. Ikke længere ned, ikke længere ned. Det er fint nok. Det sidder faktisk meget fint, tror jeg. Kan jeg se det?
Godt. Prøv lige at filme en gang her. Ja, så vil jeg gerne lige have, at du lige prøver at lukke øjnene og slapper så godt af musklerne, som du overhovedet kan. Godt.
Everything is good? Good.
Okay. Hi, everybody. Thank you for coming back so promptly. I'm going to run straight into our next speaker. And I'm pleased to introduce Professor Bo Biering-Sörensen from Copenhagen, who's going to take us through botulinum toxin therapy and how it can be optimized. So carrying on with our theme of treatment and support, and then moving on to the future after lunch.
Thank you so much. And thank you to Dystonia Europe, to Monica, to Pia, as well for inviting me here to give a little bit insights into how I think we can optimize the treatment of especially cervical dystonia. So the agenda, or you're not talking to me? Oh, no, okay, good. Go here. So, first, the agenda will be a little bit about the mechanism, just one slide to say how does this actually work, right? A little bit about the strategies for how to optimize this treatment. I'll try to emphasize especially on, it's not new, but it's a concept, the call cap concept, taking you through that. And then a little bit about why do we need ultrasound, right? Do we need ultrasound when we're doing injections, treatments in cervical dystonia? Shortly, I'll also go through a little bit about the patient-centered goals, because what is worthwhile for you when we're doing these treatments? And in the end, don't forget the non-motor symptoms that we do also see can impact the quality of life in patients with dystonia. So very, very shortly about the mechanisms of action. So this is a muscle, right? This is the nerve ending here. So this is how muscle works. We have these vesicles, they have acetylcholine, right? And we need these what called snare proteins. We need those to make sure that these vessels go down to the cleft and releases the acetylcholine. That is how muscle works, right? So we send impulses through the nerve, and then we can release it here, and then it goes directly to the muscle fiber contractions and the receptors here. Then we get the contraction. Good. So how does botulinum toxin work? When we place it into the muscle, then it's actually been taken up, because we need this acetylcholine will also be taken up again and reused. But when that is going on, suddenly we'll also take up some of the botulinum toxin in the synaptic cleft, right? So we're taking that up. And when that is being taken up, it cleaves these proteins. And when proteins being cleaved, suddenly we can't have this connection out here, and we will not have release of acetylcholine, so we'll not have a contraction, okay? So in this way, in some way, when we do this a lot, suddenly we will not be able to either also take botulinum toxin up in the end, because this is self-limiting, okay? So that is the way botulinum toxin works. It also works on, I will not talk about this, but it will also work on pain and things like that. But let's go into cervical dystonia and how to optimize the treatment. Let's start with the questions. First of all, why is there up to 1/3 non-responsive patients in previous studies using botulinum toxin? Question mark. And also, why did we see also in previous studies up to 25% and even higher of cases with side effects in these patients? Question mark. I'll leave that and I'll come back to some of these answers. So let's start. How did this all start when we're talking about cervical dystonia? Well, all the way, the principles back in 1953 by Hessler, we thought about 4 different phenotypes, right? That's why it's called Torticollis. That is what is pronounced, right? Torticollis, 4 different phenotypes. When it was established. And we have been using botulinum toxin since at least 1985. But already back then, and also now, we still have unsatisfied patients. Why doesn't this work? This is one of the most potent drugs you can use. Why does it not work in some of these patients? And it has been thought, well, might be because do we actually inject in the right muscles? Have you done a thorough assessment and actually injecting in the right muscles? Are we doing optimal dosing, right? So these thoughts were already something that Reichel, also all the back in 2009, said might be something that we're actually not doing it good enough when we're treating patients with cervical dystonia. And he thought of a new concept, did a lot of CT scans, MRI scans, and tried to look what is actually going on around the spine when we have cervical dystonia. And what he realized is that it is more complex than the 4 phenotypes we have, right? It's more complex because when we look at where the muscle origin and inserts, suddenly we have a fixed point around C2 on the spine. And then there's some muscles are inserting up on the head or above C2, and some of them are inserting below C2. And the way we could in some way find out if it was moving or not moving, we could actually make a line directly from sternum and up to cartilago-thyroidea. And if it changes direction, then it's a column. If it didn't change any direction, then it's a caput. Okay. So in this way, there was a new concept developed called the col cap. So we have to realize it's more complex. We have the column and we have the caput. So if we're just talking about the torticaput, then it is change center of rotation around C2 and above, right? Then we have a torticaput. If the torsion of the neck, where the center of rotation is below C2, then it is a column. Yeah. So in this way, we could also think about, what about if we have anteroflexion of the head or anteroflexion of the neck? And then we suddenly look at the meatus acousticus externus going down to the clavicular. Does it change or does it not change? And now we can also talk about what is anterocaput, what is retrocaput, what is anterocollis and retrocollis at the same time. Okay? In this way, we have a lot more phenotypes, and suddenly we look into which muscle do all these changes of movement, right? Because what is this all about? What is this concept all about? It's all about functional anatomy. We're using functional anatomy. I'm a movement disorder specialist. I'm also a spasticity doctor. So I treat all muscle in the body. And it's functional anatomy when we're also thinking, okay, if we have like flexion of the elbow, which muscle are doing that flexion, right? And then we attack those muscles. It's precisely the same we have to look into when we're talking about cervical dystonia. Where does the muscle origin? Where does it insert? Which kind of movements does it do? And if the vectors changes, can it actually also change how they're pulling and how the movement will be changed? So it's all about functional anatomy. So let's now try to take a few patients. So I've been quite fortunate. A lot of my patient helps me as well to teach about this concept and how we can increase the effect of what we're doing. So this is one of my patients. Let's see if it starts directly. No, it doesn't. Can you start the video? It might be a little bit difficult, but again, we will try to make a line. I'll show the line. So from Manipulum sterni up to cartilago-thyroidea, is there any change in direction? No. So this is a torsion, just slightly torsion towards the right, as well as lateral flexion to the left. Do you all agree? Right? So it's a torticaput to the right, lateral caput to the left. Okay, let's try to take the next one. Can you start the video? Now something changes, right? So now we actually have a lateral flexion of the neck. So now we have a lateral collis to the left. And again, this takes us all back to which muscles do that change of movement or make that movement towards the left. Let's start this one. And again, in the end, I don't care about the etiology. We have a lot of patients, also stroke patients, we have MS patients, we have CP patients. We also have issues up here at the neck. So we attacked it in the same way. It is functional anatomy, right? And now we can see it looks like meatus quisquus externus is behind of the clavicula. So we do know that's a retrocaput, but it looks like we might even have both a retrocollis as well as a retrocaput, but severe, especially the retrocaput. Okay, let's take this one. And what you can see in quite a few of these patients as well, they have what we usually have called dystonic tremor, right? Dystonic head tremor. But now it is in front of the clavicula, so now we have anterocollis and a little bit of retrocaput in the same way and at the same time. Let's take this one. And this is what we call shift, like antero shift or lateral shift, right? So now we have like it's a lateral collis to the right, at the same time a lateral caput to the left. It's a lateral shift. Okay, and now we can talk about all the muscles that do these things and attack these muscles in the right way. What we also have to be aware of when we're assessing cervical dystonia is that we will have dystonic muscles that is pulling one way and one direction. There's some antagonist muscles that will try to pull you the other way. And the same way, this is trying to compensate. Because if you're being pulled down here, what do we try to compensate? We try to do this, right? So we have to be aware of what are we actually attacking, and what we have to attack is especially the dystonic muscles, not so much the compensatory muscles. It has been recognized also, Alberto Albanese, and it has been recognized in new publications as well. We have to be aware of this concept. So this is traditional terms, and now we have the terms, the Kolkap concept. So looking at the functional anatomy. So let's go back to the question. Does the analysis of the patient influence the treatment response? Right? Back to the question, why is there up to 1/3 primary and secondary non-responsive patients in previous studies? This is from also a Danish hospital. It's a formal, like, this was the guideline, thumb rules, what to do when you have a cervical dystonia patient. Well, you have to inject in sternocleidomastoid. You have to inject in splenius, not talking about splenius capitis or cervicis, just splenius, and then trapezius. And then the dosages, and depending on the turns, you might change the dosage. That was how it was done. That was the muscle that were injected. So let's get back to the question. Why were the 1/3 non-responsive patients? First of all, we think patterns are more complex than the 4 subtypes, right? The patterns are more complex. And there are also uncommon muscles other than these muscles, the sternocleidomastoid, splenius, and trapezius, might also be involved in the cervical dystonia, right? And also some of the deep muscles, especially no head tremor. I'm not going to show you all the studies, but there's studies showing if you do have no head tremor, OCI is almost every time involved. And what we also have to be aware of, cervical dystonia, and some of you might have also experienced that, when you've had treatment, suddenly the patterns change, right? So we have to be aware of that and do a new assessment every time. Has it changed? So we also change the treatment accordingly. And sometimes it becomes more multi-axial, and we have to go further down in the treatment. So if we know this, we might even ask, why did we actually see effect in 2/3 of the patients? If it's so much more complex than what we previously thought about cervical dystonia. Well, we did a study also together with 6 other centers where we included 306 patients. This is all centers around Europe, but also India. And we all use Kolkap concept. We all use ultrasound guidance when we do inject. What we realized when we looked into all the frequency of these subtypes is that most common subtype is torticollis, okay, torsion of the head, right? What is the most common secondary subtype in combination with torticollis? That was lateral caput, and that is because a lot of the muscle who do a torsion of the head also do a lateral flexion, okay? So that was what we realized. And when we looked into which muscles are most commonly injected when you use the call-cap concept, if you don't care about the phenotypes, this is the most common injected muscles. Sternocleidomastoid, splenius capitis, and trapezius. So which of the muscles were most commonly injected in the traditional way? That was the same muscles, right? So that is probably the reason that you had some effect in quite a few patients still previously. Even if we look into this, even if we look into the subtypes, which muscles would most commonly be injected if we looked at torticollis, it is still sternocleidomastoid, splenius capitis, and trapezius. So very luckily, previously, what has been injected has been the right muscles in a lot of the patients. And that is why we have seen effect. But can we optimize the effect? That is the question, right? Even if we look into the dystonic the head tremor, we also did a study looking at cervical dystonia without head tremor and cervical dystonia with head tremor. And which muscles would you as experts, us as experts in the 7 centers, which muscles would probably inject, but also which subtypes would we usually see? So it's 1 or 2 subtypes. Most common subtype with head tremor was torticollis. Which muscles would we usually inject? Bilateral, sternocleidomastoid, splenius capitis, trapezius. So that is why even in patients with dystonic head tremor, they might have had some effect previously. What they didn't realize is that almost all these patients, they have also dystonic activity in the OCI. And that is what we've seen in other studies from Axel Schramm as well. So, do we need to inject in deep muscles? I'll not go through all the studies here. I'll just show you that what we also realized is that in 35.5% of the patients, 306 patients in these 7 centers, were injected in OCI, right? So it is important to remember the OCI, and that's a deep muscle. I'll show you that when we go into the ultrasound part. And also, you have to remember all the other muscles as well. So levator scapula, longissimus, and other muscles are also involved quite often when we look at the subtypes. I think this is the future, and it has also been mentioned, right? And the next speaker is going to talk a little bit about the AI. So can we use that in some way to phenotype patients and choose precisely which muscles are involved in these different subtypes when we see the patients? And even kinematics, my good friend Amanda Yock from Canada is trying to use a lot of different kind of kinematic-based assessments. So let's go into, does the technique also influence? Does the technique influence the treatment response and side effects? Question mark. How do you reach? It's not everybody, it's not all patients that is that big as me. So sometimes you need something to look into how to find the muscles, right? So we do know we can use the anatomical localizations technique, and that is still being used in a lot of centers, just anatomical guidance. Then we have the EMG, right, where we can listen to the dystonic activity. We have the nerve stim, and that is not being used in cervical dystonia because that will not work. It'll work sometimes if you do extremities, but not in cervical dystonia. And then you have ultrasound. And as my good friend Raymond Rosales also mentions in one of his publications, the accuracy in targeting muscle localization is considered to be a key factor for determining the outcome of botulinum injection, even more important than dilution, volume, and dose. You have to hit the right muscles, right? So let's start this video. It's just to illustrate one patient here and how it can be very, very slim, these muscles. This is 1 centimeter. And look, I'm holding it, and I have like 2-3 millimeters to go in, right? So this is 1 centimeter, so this is like 2-3 millimeters, and this is carotid artery right here. And now you can see I'm just piercing here. And now the botulinum toxin will come in as well. You can see it comes in here. Right? Sometimes they're just very slim. This is very effective for this patient, although that the muscle is very slim. So we have a lot of structures we don't want to hit. Just to illustrate, sternocleidomastoid, the carotid artery and jugular artery is just beneath of it, right? Here we have the plexus brachialis. That is all the nerve going to the upper arm. So if we want to inject in scalenus anterior, it's placed right here in the middle between these structures. You want an ultrasound machine to go there, right? And that is why a lot of centers not using ultrasound are not trying to inject in these muscles. They don't dare, and I do understand them, right? So let's go back to the OCI. OCI is involved, like we said, 35.2% of the times we're injecting that, right? And it's involved in almost all the patients with dystonic head tremor. So it's placed deep here. If you look at an ultrasound, we have the trapezius all the way up here. Then we have the splenius capitis, we have semispinalis capitis, we have the great occipital nerve down here. And then all the way down here we have a huge muscle. People forget how big that muscle is. When we do cadaver courses, we even show it to all the participants, how big it is compared to all the other muscles also. So an ultrasound, it is huge. It's involved in a lot of patients with dystonic head tremor, and also just the torsion of the head. So let's go back to the question, will we be able to inject in the right muscles without these guidance techniques? This is a study from Lille, and I could show a lot of studies. I'm just going to show you a few studies. So this is a study from Lille in France, where they had 4 physicians. They had more than 10 years of experience using botulinum toxin, and also more than 4 years of experience using ultrasound. So you should guess they know where the muscles are, right? They also chose not to do this study on patients, first of all, who had tried ultrasound before. Second of all, they also chose, they thought it was unethical to inject in like scalenus anterior, longissimus, OCI, obliquus capitis inferior, some of the other muscles that I showed you before. They thought it was unethical to do that without ultrasound. So that was not included here. So this is what they thought was easy, first layer muscle, most of them. Okay? And just to illustrate what they did, they placed the needle, said, now I'm in the right place. Then they put ultrasound probe out and looked, were they actually in the right place? Were they under target? Were they over target? Were the correct injection? Did they not know where they are? Right? And you can see splenius capitis very, very often injected. And even in splenius capitis, only correct injection in 67.9%. More than 30% of the time, they were not in that muscle without guidance. Right? And that was what they said, easy injectable muscle. Right? So if we also look, you might then ask, okay, also when I go teach and do educational courses, a lot of people say, wow, I've been doing this for 20 years, right? I do have effect. It doesn't matter. It just spreads. No, it doesn't spread through the membranes of the fascia of the muscles. And that is why we also need to show, does it change anything on the effect size, right? So this is also a study for 2022, where they looked at 35 patients. This was patients, again, who had not been treated with ultrasound. And then they chose to start the first time, it was anatomical guidance. And then they did all the scales that we usually use when we assess patients with dystonia, like the twisted severity subscales, disability subscale, pain subscale, quality of life, modified TUI, right? So they did all these things first, injected the patients, and then they looked, did patients just by anatomical guidance, and the assessment were the same, so Colcap concept, right? But did it change anything, just the anatomical guidance compared to ultrasound? And did they have effect just by anatomical guidance? Yes, they did. As you can see, a lot of the patients did actually have some effect on these scales. Then they did it ultrasound next time. Did it change? Oh yes, it did. Also, if they compared anatomical guidance compared to ultrasound, p-value, all of them, better effect if you use ultrasound compared to anatomical guidance, right? And I could show more studies of this. We have also shown that if we do this in a good way and a correct way, do use Colcap concept and you do use ultrasound. I also always use EMG. I'm not going to talk so much about EMG because I like to hear the sound and the EMG signals. But if you do this, we can show that you use lower dosages. In total, we inject more muscles because more muscles are involved, but the total dose will be lower, right? So we can even socioeconomically, we'll lower the dosages in these muscles, right? And there is other studies showing the same. I'll just end up also talking about the Colcap, a little bit about the non-motor symptoms. So this is the scales that are currently validated for cervical dystonia, right? It is the twisters, and for quality of life, it is CDIP 58. However, these scales do not reflect the Colcap concept or the personalized problems and goals, right? And that is why we're beginning to look into, we need to set goals for what we're actually trying to obtain, right? Also, why does it matter in cervical dystonia? How do you know what outcome the patient finds worthwhile and meaningful? Well, we need goals, patient-centered goals, right? How do you know when to change the treatment? Well, we need to see if we're actually reaching the goals or we should change the treatment. And then that's where we also need some kind of treatment diary. And also, how do you ensure that the quality in treatment, proper treatment, we need the patient-centered goals, right? And it also induces good communication, education in disease, and makes the patient feel more safe, and might even increase the patient satisfaction if we do this. Right? This I've already mentioned. So just to end up with the non-motor symptoms of dystonia. Remember, there's a lot of other things going on. And I'm going to go through all the non-motor symptoms. But we have to realize these also can impact the motor symptoms. Right? So if you do not realize the patient have anxiety, the patient have pain, sleep disturbances, depression, these can impact the motor symptoms. So we have to be aware. Just to illustrate, anxiety and depression, is that common in cervical dystonia? Yes, it is. It is very common. Even in writer's cramp, you can see it, right? And that is why these conditions are now considered not merely a psychological reaction to the burden of dystonia, but an integrated part of dystonia phenotype for some patients. Pain, is that common? Oh, yes, it is. Right? Muscle tension, you're out stamping like vessels, and suddenly you have ischemia in some of these constant muscle contraction. That is painful, inducing nociceptors, right? So commonly also located in neck and shoulders, but even a lot of patients do experience chronic headaches with cervical dystonia. Sleep disturbance, is that common? Oh yes, it is. It can even be because of the pain. It can also be because of depression, anxiety, and things like that. So these you can have a vicious cycle inducing each other. So in the end, does it impact quality of life? Yes, it does. Substantial negative impact of the quality of life of both children and adults with dystonia. Non-motor symptoms may mutually reinforce one another, increasing the overall burden and even increasing what you're seeing in motor symptoms, right? Again, the evidence for targeted therapies for non-motor symptoms are very scarce, and we have to look more into this. in studies, but we have to be aware of this and try to treat at the same time as we're treating the motor symptoms. Right? So in conclusion, how to optimize treatment in cervical dystonia? We have to be aware patterns are more complex than the four subtypes that we thought of previously. So the CALCAP concept can help the assessment. It is functional anatomy, right? And in this way, we'll also inject in more uncommon muscles, and this will reduce non-responders. The use of ultrasound in cervical dystonia makes it possible to inject in right and even deep muscles, and to document and reproduce the last treatment. A lot of times, if you just use EMG or if you just use anatomical guidance, you have no idea next time if the patient comes back and says, this worked excellent, do the same again. You will not know if you're in the same muscles. Right? But you can document with ultrasound and go in precisely the same muscle. And I will still say EMG in combination with ultrasound might help localize the most dystonic muscles. But be aware, if you put a needle into a compensatory muscle, you'll also hear sound, right? So be aware of that. It might even increase the effect. So goal setting might increase the adherence to the treatment and patient satisfaction. And be aware of the non-motor symptoms to achieve the best quality of life. So now, in combination, CALCAP concept, ultrasound, EMG guidance, structured goal setting, awareness of non-motor symptoms may enhance responder rates and treatment efficacy, reduce side effects. I haven't showed you those studies, but we will reduce side effects also using ultrasound side effects. And botulinum dosage requirements will be lower and improve patient satisfaction as well as overall quality of life. And thank you very much.
I'll let you go and sit down. So thank you so much for that. And really hinting towards the personalised approach, I think, to the treatment as well of dystonia. I've got lots of questions for Bo, but I'll keep them for the Q&A when you actually all go back up again. And leading very nicely into that, I want to introduce Heike Unger from Berlin. You're a physiotherapist, aren't you, by training? And you're going to talk us through an AI-supported Torticollis app.
Can you hear me? Oh, I can hear myself. Okay, so this white one is, no? Oh, here it is. Yeah, here it is. Okay. Well, first of all, I want to say hi. I'm a physical therapist. I think I'm the first physical therapist today. There were so many neurologists, and I'm very glad to offer you a different point of view. I would like to hold a different lecture now, but I have to about physical therapy. But I would like to introduce you or to show you the small feasibility study that we did on the use of AI-supported Torticollis app for digital movement. We have had a small working group, and I think you probably know all Professor Wissel and my colleague Martina Steinberg. You have maybe heard her somewhere. And the other ones are the engineers who were kind of programming the app. I'm a little bit nervous, but I think this is okay. Does it go on? No, the green one, right? So we've heard it already, but you know that the isolated cervical dystonia is the most common form of focal dystonia, and one of the worst thing is that it's really painful, and it's an abnormal head and neck posture, which is very painful, and it has a limited mobility and a reduced quality of life. We just heard this in the previous lecture, and there you can still see the phenotypes we were showing already. This is like the ones we are well known. I do not show you all the other phenotypes. Maybe at the end we'll see how much time we will have left. The the classical treatment is that you get botulinum toxin and you get in addition physiotherapy, and not all of the patients are getting physical therapy, and not all of the patients are taking advantage out of it. As well as with the botulinum toxin, there are patients that are just, as we just heard about, maybe not getting the right muscle injected. So what are we trying to do is like a multimodal therapy in cervical dystonia. So we supplement a digital support. And the idea is that the patients get a self-directed training and a symptom management. So this is what we do. We have had 7 participants invited in for a workshop in Berlin, in Potsdam, for 2 days, and it were like 3 females and 4 males, and we had a written informed consent, and the intervention was to show them the AI-based Torticollis app, individualized exercise programs prescribed by an interdisciplinary team, and they got all a tablet to provide it to do the exercises at home as well. Below there you can see the exercises that were on this tablet, and the idea was that they are doing these exercises on a daily home-based training and doing it. We kind of individualized the exercises for each of them, and we showed the participants which exercise they should do when they are back home. But first of all, we did a lot of assessment. We did we got a lot of data, or we did a lot of assessments that we collected the data to kind of have the comparison in the beginning, on the baseline, and at the end after the 3 months. And the assessments are always, or they are still the same. It's like the twisters, the CD 24. Then we have had assessment that showed the use of how are patients able to use the technical support, and we at the end we did interviews to see how did this work for the patients in this 3 months period of time. The idea on your left side, my right side, you can see the face of the app, and it's like the patients. I may come over here, so you can see this is the front page, and there are all these exercises that the patients could kind of click through, and we'll find out which one are the good exercises for the patients. And then they had like a daily plan what they should exercise, and usually after a couple of days they have to make a measurement, how the measurement of the head posture is after a few days of exercising. And so there was like, we have had an alpha, there's not a next picture coming here, we have had an alpha version of the app, and it showed, here you can see there is the model that we just saw before, and the model is doing the exercise, and the patient is asked to do the same exercise. But we did have an alpha version, and we have had the stick fingers that were not exactly enough. We needed more, and in the future we need more stick fingers that are measuring the movement of the head while the person is training. And the idea is that that you get an answer right away. The model is like 100%, and you get an answer in a percentage how good or how close you are to the model that is doing the exercise. So that is the app, and here you can see there is like again this page we just saw. Then they have had a calendar on it, and they have each exercise in a video, so they could kind of let the video play and then do the exercise as well, as long as the video is playing, and it is collecting the data when they did their exercises right after they finished the exercise. So that was the idea was, of course, to see how can patient get along, how can they accept an AI support in doing exercises at home. And we were kind of how the efficiency will be. We didn't look if it's really gonna help to change the movement, but how it's gonna be for the patients in a 3 month period of time. So again, the assessments we used were the questionnaire of the quality of life to kind of see maybe the quality of life changed in the 3 months period. The twisters is especially for the pain, to measure the pain and the change of the pain. We were just hearing about this before in the previous lecture. And what else we did is this technical assessment to see how is the usability of this app. And this is just a questionnaire of 10 questions where you kind of have like a scale of 1 to 5, where you can say it was easy to use it was easy to measure, or it was not. It depends how your own experience has been. The NASA TLX is a test where you can kind of measure the workload, how stressful it is to do it. Is it too much to work with the app, or is it easy to handle? So you have kind of the possibility to measure the acceptance of a technical support for the patients. And it's as well, it's just a questionnaire where you can kind of ask the question. And all these data we did in the beginning, on the baseline, and after 3 months. And the last ones were the ATI, which is where you can measure the affinity to technology development or affinity, so that patients, if they are used to, as most of us are used to using a smartphone, yet we didn't do this 15 years ago, so now we got this affinity to use a smartphone. And at the end, we did these interviews, which were really very interesting to kind of, it's like a qualitative, not a quantitative study. Then at the end, we just wanted to see how the individualized experience has been in after 3 months. So the results were kind of interesting. We started with 7 patients and we ended with 5 patients. Why? There were 2 patients that had a tremor-dominant torticollis, and they got so stressed. We were just hearing about the different phenotypes. They were so stressed by this exercise, because the exercises are really slow. They are not, they are not fast. They're really slow, and the tremor got so bad during this exercise that they decided they're not continuing. That's okay. That's an experience we had to make. But the other ones finished the 3 months, and they really enjoyed and had a big affinity to the technology. Interesting was, and that's why it's that big, it was significant pain reduction. So for the patients, all of them described that the pain got better. This is what we measured with the twisters. The work-related symptoms decreased. The symptoms during activity of daily living, they decreased during daily living, and the overall dystonia severity, the twisters, improved markedly, decreasing from a mean score from 10 to 6.65. This is a very good score for this short period of time. We have had a small crowd, but still, it was interesting. The quality of life increased for the patients, and the emotional well-being was definitely better, and the daily functioning was better. The usability, there was not much problems by using this application, and the workload was they didn't realize that this was a hard workload, so it got a lot better after using it a couple times. The qualitative feedback from the participants was, first of all, the positive aspects. They got a improvement of posture and mobility, which is definitely a very important improvement. Then they had increased motivation and energy in daily living. And all of them said it was a good usability of the app and the terrible devices. The challenges where to integrate exercises in a daily, in a everyday life, in a daily life. I think this is always a problem. It's not just the problem when you use an app. It's always a problem to do your exercises every day. The technical issues that we have had, we had connections problems. Sometimes the internet was not good enough. So there was like this technical part was more a theme of problem for the engineers than for the patients. But it's kind of bad when you try to make your exercises and it's not possible because of the technical issues. And then there was sometimes the model, the exercise model. There is a noise, or she's saying something, and there's like there was not the same noise than in the movement. So there was this asynchronity in the image and the audio. But this is something for the programmer as well. So there was like we had to figure out what is the real problem. The improvement we have to make is we need definitely more stick figures. We call it stick figures, so we can measure the point in a clearer way for the patients as well. And we need a greater flexibility of exercises. There were a few exercises, now we took them out, that were not really the good ones for long term when you use it for long term app use. And the additional visual markers I just talked about, we need definitely more of them. So the findings were the participant satisfaction was very high and the motivation as well over these 3 months. The significant reduction of pain was interesting, and the improvement of the quality of life. I think that was really interesting to find out, and it was a very good acceptance of digital support. Of course, it was a very small sample size. We did not have a control group, and the technical limitations that are in the alpha version are still a big problem, and so of course we cannot conclude out of this small group of a higher group and in long-term changes. We have no idea yet, but of course we would like to do more further studies and do it on a bigger group and have a control group. That would be wonderful, but still we are working on the technical challenges we do have so far. This is the group for the weekend, and it was like we have had 2 days, and some of them we are still kind of in contact, and the app is now available in the App Store, but it's not finished yet because we're not really happy about the technical situation right now, so we need a little bit more to be made as well. Thank you for your interest.
Thank you, Heike. If I can ask you to actually have a seat for us, because we're going to do some Q&A, and if I can ask Bo to come up as well to the front. Do we have a handheld microphone? Thank you. One for the front. Have we got 2? One for the front and one to circulate. Yeah, there we go. Is it on? That one. There we go. Okay, folks. I mean, I've got tons of questions, but I don't want to jump in. Please feel free.
I can ask a question.
Go for it, yeah.
I love this app, and I do a lot of collaboration with Jörg. So, my question was, I don't remember, these patients that you included, 7 patients, the 5 patients that completed, did nothing else change because they were also receiving botulinum? Or did they not receive botulinum for their dystonia?
All of them did.
So
by Jörg.
By Jörg, yeah. So that was not changed at all. The treatment of the muscles and everything, that was totally stable.
In this period of time, yes.
Yeah. Okay.
Yes, because it was like they got into a baseline, and then after 3 months. So we have we didn't have the data yet.
questions.
My question's for Bo, please. I was very interested in where you showed the difference between using ultrasound and EMG to guide the injection, and I've experienced that myself. My previous consultant just used to use his fingers to find the correct muscle, and the consultant I have now uses ultrasound, and I can feel the difference. Sadly, now I've developed antibodies to the toxin, and I wondered what your strategy would be for that.
Well, it's very unfortunate because, well, it is very seldom to develop the antibodies. What we usually see is when we go quite high up a dosages, and we've used it for many, many years. Sometimes if you do like a washout, like 6 months, but that is very tough for the patients. You're in the washout.
Yeah, my consultant very nicely called it a toxin holiday.
Yeah. Sounds better than washout, toxin holiday. Yeah. Others try to change. You might, if it's botulinum type A, sometimes people change it into BoNT B, because then you won't have the same issue. But you have to realize that immunogenicity for BoNT B is even higher. So often after already 6 times, you will detect also antibodies for B, but in the meantime, you will have a washout of type A. Okay. Some centers even try to change the botulinum toxin, right? I don't know which brand you were on, if it's Botox, Zomin, or on. You've had them all. Yeah. Okay. So you have tried to change between them. But sometimes we do see there might be a little bit different when you try. What we also have realized, and also in a lot of the studies of immunogenicity, is that although that you do have neutralizing antibodies, you have to be aware there is antibodies against the complex proteins, and you can have antibodies against the botulinum, the active part, right? So you can have antibodies against the proteins that will not in any way affect the effect of the botulinum toxin. But what we're also seeing in quite a few studies, also from Philip Albrecht, is that if you go higher up in dosages, you might still have some effect, although that you have neutralizing antibodies. So that is in some patients where we're saying we can't do the drug holiday, we have to do continue, then sometimes in increasing the dosage, we'll still see some effect of it. Yeah.
Yes, I have a question about botulinum toxin type A. I know there are different brands, and I was wondering if some of them, maybe can cause more pain than other ones. For some people, maybe not for all, but maybe for a few people.
I use all 3 brands. I don't see a difference between pain. What I do see a difference regarding pain of the injection is choosing traumatic needles compared to non-traumatic needles, and what kind of needles you do. And also, if you do ultrasound, do you in plane technique or do you out of plane technique? Because then it's longer direction into the muscle, right? And also how many injections you do. The other thing that I also see regarding pain, in some patients, depending on the dilution and how much the dosage you put in, right? The amount you put into the muscle. Sometimes you like to have quite high units into the muscle, and it's a lot of dilution. If you put a lot of that in the same place, in some patients things that is quite hurtful. So then you have to divide it between different places. That is what I usually see when I do treat patients. I try to find out first of all, choosing the needle. We changed the needle from what was called Bojex into Ambu traumatic needles because it was just less harmful for the patients, right? And then we try to divide the dilution, but I have not seen any difference in pain between the BoNT A types.
Yes, I probably also didn't say my question very well, but I'm thinking about pain 1 to 3 weeks after, like headaches and
Okay.
Yeah.
So, like, you feel like and some sort of side effects of headache?
I'm sorry, I experienced that only with one type that is
Okay.
not so commonly used where I live.
And multiple times where you tried the same time. Okay,
Yeah.
it's giving. Oh,
Yeah,
interesting.
and when I went back to the other
Yeah.
type A, then I didn't have the same
Okay.
issue.
Interesting. I haven't experienced that with my patients, but what I have experienced also regarding pain, depending on where you actually place it, some patients really get best effect if they do have pain from the cervical dystonia going very high up, but some patients even say, well, I get headaches if I go too high up on the muscle. So it's very patient dependent what we do, right? And that is why we need these very patient-centered goals and everything that we're doing, right? So, but I haven't experienced specifically that thing, that changing the botulinum toxin would change that. But again, if you have experienced multiple times that with that you get the headache, with the others you don't, that's quite interesting. I don't think I've seen any publication specifically on that. Yeah, interesting.
Two questions. Do you have any experience of injections in the steam bar and false vocal cords?
So in Denmark, it is placed very few places where it is actually the ear, nose, and throat doctors who is placing the needle, right? So it is more the ear, nose, and throat doctors who is doing the procedure when it is in the vocal cords. So am I doing that? No. I'm doing like longus colli, longus capitis, going very, very deep with ultrasound where it can go in, but not into the vocal cords. That is actually the ear, nose, and throat doctors in collaboration, of course, with neurologist who's setting the diagnosis. Yeah.
Okay. Do you know why I didn't got any effects of Botox when I also got hyperthyroidism and hyperparathyroidism, no effects of Botox?
That is a very interesting thing.
Yes.
Is there crossover antibodies, things like that? Have I seen it? I've seen it twice.
Okay.
So I can't be sure because it's not very described in the literature. But have I seen something like that, what you're saying? Yes, I have seen.
Yes, and when I was cured,
Yeah.
I got good effect.
It is very, very interesting. I've seen it twice, as I mentioned. Yeah. It should be published, so people are aware of that when you do have terrorism. It might affect the effect of the botulinum toxin as well. Yeah, very interesting.
Actually, two questions. Curiosity about this AI identification of the muscles.
Yeah.
Where are we actually? Is it something being used somewhere in Denmark, for instance? That's the interesting part for us. And the other one is actually, are there any research about toxins which last longer than 3 months?
Yeah, both, yes. I'm in a great collaboration with my dear friend Jörg Wissel. So that is what we're hoping that Jörg very soon will develop something. He's also in our spasticity group where we have developed a spasticity app in the same way we want to have the AI, because it's all about functional anatomy, and can the AI help us choose these muscles, right? The second question was long-lasting, the long-lasting. There is quite a few studies on type E and other types as well, and also recombinant toxins. So there will things are coming out. Right now, currently, studies is going on. So we hope to have longer-lasting toxins in the near future, yes. And it is not just one company, it's more of at least 2 of the companies who's quite long on this with the longer lasting, yes.
Any other questions from the floor? Do we have any that have come in online? Yes. Yeah. If you can, Monica, that would be grand.
So we have one person here. What should we do if our doctor doesn't want to apply the Botox, botulinum toxin, under EMG or even ultrasound? How can we?
That's a good question.
What can we do as patients?
Well,
What can we tell our doctor?
Well, again, patient education, I think, is key, because you should know about the evidence and why we should apply these things. So you can even go to your physician and say, well, we do know this is important. You can just as a physician say, well, there's no evidence of that. There is evidence, right? So you can apply that and tell your physicians, this is important, right? I've been to an educational meeting. We've talked about this. I've been shown the evidence. Please, be aware of it. But what you also have to be aware of is a lot of these physicians are saying, well, it takes more time. It takes a long time even to be educated in this. I would say it's a steep learning curve. I do a lot of ultrasound courses, right? It is a steep learning curve. So if you just start applying from the beginning, suddenly you just feel handicapped if you don't have an ultrasound. I don't want to do any injection without ultrasound any longer. Then we have to change to when I have the ultrasound machine. So it is a steep learning curve, and you have to get these people on board and realize why is it important, right? In some way, but we still have even physicians in Denmark who's not using ultrasound.
And I also think the training of the neurologist to be able to use the ultrasound in the right way.
Yes.
Because I think there are also neurologists using it who are not enough trained.
Who doesn't know what they're actually doing. They're saying, this is a muscle. Yes, it is.
So the training
is the right muscle. I don't know.
The training is necessary.
Agree.
Yeah.
We need thorough training on ultrasound, as well as the assessment. Because what I also always say when I do the ultrasound courses is that it is very, very important to hit the muscle you want to hit. But if that is the wrong muscle, it doesn't matter. So the assessment is the first thing you have to be very, very good at, and choosing the right muscle to inject to get the best effect. And then actually injecting in that muscle, right? Yeah.
Go for it.
Thank you. The question for Heike. I'm from the UK. And in the UK, it is notoriously difficult to get to see a physiotherapist. I've had dystonia for 20 years, and the only way I can see a physiotherapist is if I pay privately, which I do, but not everybody can do that. And I just wondered if you could very briefly say what is the position like in Germany?
It's similar. It's the same. So there are, I think, the same situation for the patients, that there are not, let's say, enough physical therapists that know about the disease. This is the fact. And I'm teaching at the university my students about the dystonia, because most of the physical therapists have never heard about it. And so a lot of them we have to say that's part of the truth, is that a lot of patients do see for many years an orthopedic doctor before they get to see a neurologist that diagnoses the dystonia or cervical dystonia. This is what my experience. But a lot of physical therapists treat some problems at the neck and do not know what dystonia is. And sometimes I have the situation that the patients come through a physical therapist that says there is something else going on, and so the patient sees a neurologist that does the diagnosis, and after that they try to look for a physical therapist that knows something about dystonia. So this is really a big problem. It's a really big problem, yes. And because it's such a rare illness, it's just that there are not many physical therapists. I try to offer workshops, but there are not that many physical therapists interested in, just because they might have maybe one patient in 5 years, for example, right? So it's really there's a big gap in the looking for a physical therapist is one thing, and then find a physical therapist that knows what to do is another thing. In Germany, it does not have anything to do with the private or with the social security. That doesn't matter. It's just the competence of the physical therapists. Big problem.
Well, you mentioned
doctors say they don't have time to learn new stuff. Well, I think we need to address also the political issue about that. And we need to get involved in that. Because the medical, the doctors, I mean, there was a demonstration in Sweden just recently. I saw that doctors in Lund and also Gothenburg, they had a demonstration. They went into the park and said, we're having lunch. The pressure on the doctors performing it has to be addressed.
I totally agree, and even right now in my hospital, a lot is going on, being destroyed by politics decisions, and it's right now being discussed. So some of the patients, I also treat complex renal pain syndrome, and these patients can also get dystonia. It's severe painful, right? And we were one of the only centers in Denmark who's actually treating with botulinum toxin for this pain syndrome. And right now, because of all these things and lack of resources, it's just being said, we might not in the future be able to treat these patients because we don't have the resources to treat these patients. And just socioeconomically, that is just stupid, because it'll cost so much more in healthcare, in what kind of resources needed at home, and they're not going to work because they don't get the treatments, things like that. So I totally agree. We have to go to the politicians as well and explain why do we need to do this. And we, as I mentioned, if we do this also in cervical dystonia in a thorough way, you will even reduce the cost of botulinum toxin, right? That is so economically beneficial. And you'll have patients who are so much better, might even be able to work more, might even be able to have better sleep, everything, right?
I have an additional concern. I've been doing a lot of union work and in office. And I wonder, we have this musical aspect of dystonia. What about all the desktop and working on computers and the cell phones and so on?
So you're talking about more task-specific dystonia and musicians dystonia and things like that. Yeah, we have to be aware of that. Might even be increased when we have to do that even more, right? We have even seen physicians developing more task-specific dystonias because of this as well, right? So that we have to be aware of.
I think that is an important message to carry forward.
Anybody else at all? Oh.
Do you use the same dose in muscles?
No.
No.
Differentiate between what is the goals of and how severe is the muscular activity. I might even sometimes when I use the EMG try to differentiate. Okay, I would go higher up in dosage, but before I go in, I have chosen the muscle because I know the functional anatomy. So I've chosen the muscle. When I go and say I have like a scheme in my head, what kind of dosage would I probably use? And sometimes we have to I would always like to say, first injection, everything is great. Problem solved, right? We've reached the goals. But sometimes you need to titrate a little bit depending on the patient as well. Right.
I have a question. So for you, Heike, you said that the app is in... It's in the App Store. So is it possible to download it and test it? Or do I need guidance from a physiotherapist?
Well, you need to get the access through our group. And yes, it is available in the App Store so far, but we are kind of working on it. I just told you, it was the alpha version, and right now
it's not really launched.
It is, yeah. It is launched, but you need someone who kind of let you in. And as long as it's not B version or beta version, we kind of keep back to. But it is launched, and I think it's just in the App Store. It's not for the Android. It's just in the.
Okay, thank you. And then you mentioned that you like to have a treatment diary from the patient. So what does that treatment diary look like?
So there is one that has been developed together with Dystonia Europe. Yeah, so that can be used, right? We have also developed one that is it's called Specific Diary, but it's precisely the same, because what is important is the goal setting, right? So setting SMART goals, specific, measurable, attainable, relevant, and timed goals for the patient, and then actually letting the patient evaluate if they're reaching the goal, not just letting the physician think they are, if the patient is reaching the goal, but that is each week they're just making a mark according to what we call goal attainment scaling, just making a mark. It's just a mark each week if they are actually reaching the goals. And then we get a lot of information from that. But what is also in that diary is that we would like to have the therapist as well. There is assessment if they think the patient is reaching goal. If it's pain, of course, they can't assess the patient is reaching goal. But if it's something like being able to do specific things, then they can get on board as well and assess these things, because they're seeing our patients more common than we're seeing the patient. If it's every 3 months, or sometimes I have flexible intervals, we see them every 2 months or whatever, right? So also getting feedback from therapists is key sometimes to change the treatment accordingly, according to the goals.
I think that's what we patients miss sometimes, that there is no communication between the different people who, the different experts, the physiotherapist, the neurologist, and maybe also the psychologist.
Yeah. That is what we need in the future.
Yeah. The multidisciplinary care. Yeah.
Just want to make sure nobody at the back, has anybody got any questions? Or do we have any online questions coming in, just to finish? No online, okay. So I think we're going to, and please don't go yet, because Monica wants you to do something, the guys and Jill want you to do something. So I think thank you so much to both our speakers for that really, if like, multidisciplinary, patient-centric. So thank you so much. Thank you. And Monica and Jill would like you to do something, and it involves orange T-shirts. So, oh, you don't want to do the photo? No. Okay. 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 You're happy to break for lunch? Okay, perfect. All right. Thank you, guys.
you just say the days of the week?
Can you just say a few words so we hear your voice?
Okay. I have 7 children. My husband, I've been married.
Okay, everybody, thank you for coming back. That's always good. Welcome back. Just to reflect, this morning we looked at current support treatments and therapies, and now we're going to change tack a little bit with a little bit of a look to the future. And with that in mind, I would like to introduce Professor Andreas Puschmann, who's from Lund, to talk about genetic testing and, to Monica's point, genetic testing in dystonia.
Well, thank you so much for this kind invitation to come here. It's quite interesting to have so many people from all over Europe coming to Malmö, and Lund, where I live, is just 15 minutes away. So for me, it was very easy to come here. Yeah, I'm going to talk about genetic testing in dystonia, and that's quite an interesting field where many things have happened. I want to show some disclosures. So my main disclosure is I'm very biased because I think genetics is fascinating and is interesting. So I'm going to talk about very interesting developments, I think. What happened now? Right. I also will mention a congress that's going to be in Milan in November. And this is my disclosure because I'm active in this IRPD association. Now, genetic testing in dystonia. Some people think it doesn't make any sense. It's just a waste of money. Sometimes heads of departments think like that. And other people say it's very important. We need that. It gives us a diagnosis in 4 weeks. We don't need to do any additional tests. So there are very different opinions about genetic testing for dystonia. Both can be true. So we need to really look at details. We need to understand when genetic testing makes sense, when can we find people who have these genetic forms that we can find today with the genetic tests there are in hospitals, in clinics that are available, and when it doesn't make too much sense. Now, I always had this problem with the word dystonia. I think it's a very difficult word when you think about it, because in most other diseases, you would say, I have pain in the leg, that's a symptom, and then the cause is the leg is broken. You don't have the same word. But in dystonia, you use the same word for everything. Dystonia can be a symptom, a sign, a syndrome, and the actual disease that's behind it. And that makes a study approach quite difficult and quite, sometimes you really have to concentrate and also teach young residents in neurology, what is dystonia? This article says dystonia, but it means something completely else than a different article. So it can be a sign, like cervical dystonia is something that's a sign, maybe a bit more than a sign, a pattern. But then it can be a syndrome. I understand you heard a lot of expert information this morning about Myoclonus dystonia, of course, but then it can also be a disease. So a specific type of dystonia is also a name for a disease, for an entity that is very clearly defined, sometimes genetically defined. But we always use the same word, dystonia, which makes it a bit difficult. Now, when we think of classifying and trying to find out exactly what type of dystonia we mean, we can ask certain questions to use for these classifications. And I understand that you all know Professor Albanese, who has worked intensively on this question, how we can try and classify and find out and define the exact subtype of dystonia. So questions include, when does it start? Does this dystonia start already in infancy, or are people born with dystonia, or does it start at a later age? Which body parts are involved? And is it one part of the body or several? You know, there's focal dystonia in one part, it can be segmental in several adjacent parts, or it can be generalized, just affecting many parts of the body. Another question would be the time course. Has it started abruptly? You can get dystonia because of stroke. Then it's not the disease dystonia, but it's the symptom dystonia. And that just comes relatively quickly, a few hours. Most of the time course would, of course, be much more slower. There are also time courses in between. Subacute development, for example, in inflammatory diseases. A bit quite rare, probably, but it might just occur within a few weeks, perhaps. So there are different time courses. They can tell us a lot about the type of dystonia we're talking about. Is the dystonia persistent? Is it there all the time, or does it come and go? There are forms of dystonia with a fluctuation, where dystonia is almost gone in the morning, and then towards the end of the day it gets more and more intense. And there is paroxysmal dystonia that just comes in episodes, in fits almost. I'm going to talk a bit about those. And then, does the person who has dystonia have other disease signs? Is the dystonia just dystonia, or is there other neurological disease signs, Parkinsonism, myoclonus, as you heard, or is it combined even with other disease signs, such as, I don't know, liver failure, whatever, something completely else in other parts of the body? And all these aspects you can use to try and find out what type of dystonia we're talking about, and that has importance about genetic testing, if we think genetic testing might be helpful or not. Also, we still need neurologists to do some kinds of neurological examination, and physiotherapists as well, of course. This is an old picture that I found. It was in the Lancet in 1898, many years ago, and it shows a family where several people obviously have cervical dystonia and maybe other forms of dystonia. So we know for a long time that sometimes dystonia runs in families. Sometimes there's a genetic impact and genetic factors, quite obvious. But we of course need to know that genetic causes is only one of possible causes. It can be acquired. You can get dystonia because of medications, toxins, trauma, as we will hear about more, lesions in the peripheral nervous system, in the central nervous system. It can be a bit of a combination of these factors, and sometimes the cause is also quite unknown. Many times we just don't really know yet. If you look at it from the other direction, which known forms of dystonia are genetic? Which forms of dystonia do we know that have a genetic cause? Maybe it gets easier. And I want you to go through with some of these groups with you. Isolated dystonia, where you only have dystonia, not much else. There are genetic forms. I'm going to show one of them, but not so many. Then you have these combined syndromes. I'm going to talk about dystonia that really only comes at certain points in time. That is more often genetic. And then show you some examples of these more severe neurological disorders that often start in childhood, start early, that have also dystonia. So everything is dystonia, but very different aspects, very different diseases in a way. So let's see. I want to show you this family whom I met many years ago when I was in the US, actually in 2010, I think. This is an index patient. All right, and can you turn your head in all direction? So this is a person who had cervical dystonia. Quite typical onset, 45 years. He had some tremor in his head. He was unable to work because he was actually working as a firefighter, and that was quite difficult for him. He had this sensory trick, so I think you all are familiar with this type of dystonia. He received botulinum toxin, it helped him. Now, his sister is this person. Can you listen to her voice? Say a few words so we hear your voice.
Okay. I have 7 children. My husband, I've been married 15 years. I got 7 kids. Tracy, Eric, Stacy, Chandra, Travis, Keenan.
You hear there's some kind of spasmodic dysphonia in this sister of the man I showed you before. Now let's look at the mother. The mother also has spasmodic dysphonia, but the other type. I think I have to put the sound back on.
Say the days of the week.
And she has some movement around the mouth, has had blepharospasm. So this is all the family. So when you think about it here, what is inherited is not the exact same type of dystonia, but what's inherited is a tendency to develop the dystonia somewhere, right? It's still in the upper body, but it's not exactly that all these siblings and the mother had exactly the same dystonia. Actually, one of the other siblings whom I met had some writer's cramp, but we didn't film it. So the genetic trait is sort of is there, and it makes it easier to develop dystonia somewhere in the body. And the gene that we eventually found in this family was a GNAL gene. It's one of these 12 genes that we know today that may cause isolated dystonia. Now, I'm sure you've heard of some of them. So TOR1A is, of course, dystonia number 1. THEP1 is dystonia 6. So some of them are a bit more common. GNAL is probably also one of the more common ones. I'm interested in the second column there, where it says the median age of onset. And when you look at them, most of them have an early age of onset, right? It's not the normal type of cervical dystonia, with some exceptions. Maybe the ones I just showed you are actually on the higher end of the age of onset, but some start at 2 years of age, 7 years, 5 years. So genetic forms of dystonia tend to start earlier than others in a very general comparison. Now the next form I want to talk about is the paroxysmal dystonias, and they're quite interesting, quite different to normal dystonia. The main point I always try to make to residents is that it's very important that we as neurologists recognize that this disease exists and not say this is functional, I don't see anything, it's nothing. Because what these people have is they look completely normal. They have no symptoms when they come to us in the clinic. They have no symptoms most of the times. But in certain circumstances, they will get a short episode of dystonia. I will show you some videos in a moment. There are different forms. These episodes are usually triggered by something. So they can be triggered by movement, voluntary movement, such as sitting down and then suddenly getting up. Or they can be triggered by exertion, such as, really running and doing exercise, and then at the end of the exercise, when energy disappears, there comes a period of dystonia. Is usually combined with other types of movements. It's not only dystonia, it can be a bit faster movements that we would call dyskinesia, so this is why they have these kind of double names. Usually this affects children or young adults, starts at that time, and can be treated relatively easily. And these are genetic disorders most of the time. Let's see, there's a video that shows 3 patients from Asia, where one of these diseases is quite common, and they are asked to provoke this dystonia by doing this movement, jumping, running. And you can see this person now gets a bit of dystonia in the hand, not very much at all. And that's typical. So after a movement, this starts. It's called kinesigenic, elicited by movement, by bodily movement. The second person is asked to do the same thing. You see, they're all young people, right? They happen to be men, but it can be men or women. And you see, he gets much more of a movement. Quite bothersome in a way. If you imagine you're a young person and you are in a university and you study and you just want to go out of the corridor and you get this kind of movement, everyone looks at you. And this third person has the most severe manifestation. There, even these kind of movements that people think is very unusual, right? I guess that some of these people would look at these movements. Some of these people would be considered functional. There's something wrong, right? But it's not. It's a genetic disease that is called paroxysmal kinesigenic dystonia. It's this PRRT2 gene variant that can be found easily. And that's the definition. There's sudden attacks that just come triggered by this voluntary movement, young onset. Some people feel something a little bit before. It can come whenever you do these movements, 100 times a day, 20 times a day, whenever. And in this particular form, there's also a connection with some forms of epilepsy and some forms of migraine. When you think about it, these are all episodic disorders that are not there all the time. They just come sometimes. And the reason why we want to find these people is because the treatment is very simple. You give them a small dose of an seizure drug, and they get rid of these problems and can live normal lives. So it's very pleasant to find and very easy to help them. Genetic testing can be done in this, but sometimes I thought it's not necessary because it's clear. It's this disease. Once you know the pattern, you recognize it, they get better by simple treatment, and then you know you don't need genetic testing. May not be recognized. That's the main problem, and I think there's a considerable, an enormous social, psychological burden on these young people who cannot live normal lives before they're treated. So we try to find those. Now, the third part I wanted to talk about is all these many neurological diseases that start early and that can include dystonia. And I used ChatGPT just to ask these questions: which diseases are there that can cause, which genetic diseases are there that include dystonia and other signs? And you see there are very many. Now, each and every one of these diseases are rare. They're not very common. They are always combined with other signs, other symptoms, other problems. And here, of course, genetic testing is very valuable to find out exactly what this is. And there has been a tremendous development where we can do testing now. Pediatricians use this a lot, but also in young adults we do this. We have these people with dystonia and other signs together. We don't quite understand it from the beginning, but we do these tests and have a very good chance of finding the diagnosis much easier than previously. So here we do genetic testing. These are young people most of the time, usually quite severely affected. I've tried to look for videos that I'm allowed to show here in public, and it was not easy, but this was one of them. You see a person who was examined by Dr. Bhatia from London. He will soon come. And that's a 21-year-old man who started to drag his leg or his foot when he was 18. And then he developed a number of other signs: cognitive decline, personality changes. So quite a lot of severe disease, obviously, not only dystonia. And he has this problem that there's a dystonic movement as he walks, and he falls backwards. You see, he's quite disabled, really, from what he has. So this is one of the, now this comes again, is one of these forms of dystonia that start early, but that actually are not only dystonia, but many other things as well. And there we do genetic testing, and this one was PLA2G6 that was found in that patient then in 2009, and there is one of these many genes in this list. And of course that helps to find this diagnosis and know what it is and what to expect and how this can be, how we can care for these people. I found another example here, similar in some way. Let me show the video directly, maybe. So there's some Swiss German there in the background. But you see there's a severe dystonia in many parts of the body, and when you read the history on the other side, this person had problem since childhood already. He has this term of mental retardation that I wrote in the article, a gait disturbance since early childhood. He used to fall a lot because of also episodes with more dystonia probably. He had difficulty speaking. He had some signs of Parkinson's. So many symptoms together with dystonia. Also here, this is a genetic disease. The patient's sister had very similar symptoms. This is a genetic disease that was found by these people in Switzerland. So we come to these kind of diagnoses and diseases. So this is a gene name. There's a variant in the gene that is called WARS2. It's a recessive disease, and then some of these disease names are quite complicated. Mitochondrial neurodevelopmental disorder with abnormal movements and lactic acidosis with or without seizures. I'm not sure this is a better name than dystonia, but that's the present designation of these disorders. So some of these, there's of course an evolution where you find genes, and then you see that genes can cause all kinds of different symptoms, and then you try to put everything together in a name. Sometimes it works better than other times. Now, if we should get back to the question, whom to offer genetic testing, which people with dystonia have a reasonable chance to get a diagnosis through genetic testing. We looked at a number of patients in Lund. We included 120 patients with dystonia in a study. And then we wanted to do genetic testing, but we didn't really have money to test 122 because it was expensive, at least at that time when we started. So we tried to find those people who said they had someone else in the family with dystonia, or who had some kind of unusual, one of these more unusual forms that we think that here we would find something. So we found 14. So 14 out of these 122 we tested. The other we were a bit economical there, as you see. Now, these had a mean age of onset of 37 years, so already a little bit younger than most other people with dystonia. And in these we found 2. So 14% of those we tested had some kind of genetic disease that we could find out. And the 2 that actually had the genetic diagnosis had very young onset again. One had symptoms since birth, from birth. The other one started to have symptoms at 8 years of age. Then we found other interesting things that we started to continue, but they're not really diagnoses that can be used completely at the clinic at the moment. There is a much larger study that comes from these 2 large registries, Dystract and Dystonia Coalition, and I understand was collected in Lübeck in Germany. They looked through 1,895 cases with patients with dystonia, index cases, so 1 from each family. And they had isolated dystonia, so they didn't really select for these people with all kinds of other symptoms. And there were a few things to keep in mind, so many of them were already excluded, some they were a bit younger, there was some selection as well, as in many of these studies you read their selection. But the main result was that 8% of these had a diagnostic variant, so had a genetic test result that really led to a diagnosis. And again, these people who had the genetic types of dystonia were very young. They had a mean age of onset at 19. So types of dystonia that start early are much more likely to be genetic, at least genetic in the sense of what we can discover today. And when you look again much more closely then they did a lot of analysis, you see that young age of onset means that you find more diagnoses. Generalized dystonia is something, if you have generalized dystonia, it's much more likely to be genetic than focal dystonia, and these additional features. So if you have other disease features, it gets more likely that you have dystonia. Now, the group in Munich by Dr. Zech has put this knowledge together, and they tried to make an algorithm. When we now meet patients, which patients should we select for testing? And it's basically the same, but in the other direction. So they think that you give points, right? So if the person who comes to you has had dystonia since before 20 years of age, you get 2 points. If it is generalized, it's another point. And if the dystonia has other symptoms, you get additional points, and then you have such a point system. And when you have many points, 5, all of them, then you find a genetic diagnosis in 1 of 2 persons tested, in half of them. That's quite reasonable, we think. We want to, that's something that we want to invest, right? Because these tests also cost money. But these are the people with early onset, before 20 years, with generalized or segmental dystonia, and with other non-movement disorder signs. So a small group of people where we have a high yield with genetic testing. On the other hand, if you have adult onset dystonia that started after 21 years, so still quite early, and it's isolated and focal, you almost never find anything. 1 out of 50 persons. And my head of department says this is too many. We cannot test 50 people to find 1. It's too expensive. And maybe it doesn't have that much impact either on what we actually need to know. So with that, genetic dystonia, genetic testing in dystonia can be both extremely helpful, can be no use at all. I would like to sort of group it like this: if the dystonia is isolated, if it is starts later, usually we don't recommend genetic testing. It's not 100% always, but it's usually for these very unusual forms of dystonia. We sometimes do genetic testing if we think it helps us. And really the big benefit lies in these people with a lot of other symptoms, early onset, very severe disease where you really want to know what this is, what can we do, what is it caused by. And their genetic testing has really been a great help and has been developed and gets better and better. With that, I just want to invite you all to this Congress. We will have the 31st World Congress on Parkinson Disease and Related Disorders. It will be in Milan in November, mid-November. And you see many familiar names there. Professor Alberto Albanese is Congress Chair. Elena Moro is responsible for the scientific program. And this is so there's a lot about dystonia and similar diseases there. And it would be great if we could meet there again, of course. Thanks a lot.
Thank you so much. I think we've all got a lot of questions to ask you. We will have a question and answer session, so I will pull you back onto the stage. If you just want to remove your microphone, that would be brilliant. So I wanted to ask, just in the interim, Monica, just your takeaways so far on the day, please.
Oh.
Not that I've put you on the spot or anything.
No.
But yeah.
No, but I must say that I'm very happy and pleased with the day, and I think we listened to interesting presentations on different topics about dystonia and treatment, and I have to highlight the testimony of Salvatore in the beginning of the day. It really moved me to tears when I was listening to him. And it shows how important it is that we, the patients, that we tell our stories and that they are heard between us, but also for the experts so that they hear other patients than the patients they see in the clinic, and also for our partners, the industry, that they hear these patient stories and the different needs that we have. And then I also have another word that I like today, patient education. That's what this is today, patient education, so that we can bring what we learn here to our treating neurologists, physiotherapists, and be those educated patients that we have to be in today's society.
Thank you, Monica. And I now want to welcome to the stage, just watch that wire there, that's it, Professor Chi Wang Ip from Würzburg. So I think, Professor, you're going to talk to us about movement analysis, which is AI-based from and translational from animal to human models. Is that correct? As
yeah,
a
that's
layperson's
right.
translation of it. Yeah.
Yeah. Okay. Thank you very much. Yeah. First of all, thank Dystonia Europe and also especially Monica for inviting me here. It's really a pleasure to be here. And yes, so I'm going to talk about artificial intelligence-based movement analysis. I want to start my talk with a question. So, can we truly assess movements objectively just by watching? So, to answer this question, imagine you're just sitting in a busy restaurant. People are moving everywhere. And some of the people are for sure eating. Yeah, some of them are talking about what happened over the day, and some are expressing their joy in life by dancing. And here's the point: we all see the same scene, but do we really describe it in the same way? And I don't think so. So my hypothesis here is that AI makes movement analysis objective and measurable when the human eye is not enough. And this is how it could look like. Yeah. So I'm not saying that we do not need any more clear observation, for example, by medical doctors. No, I'm saying that we are placing a second lens on top of what we see, so that we can make movements really objective. Yeah. And now getting back to the clinic from the restaurant, in my daily practice, I see a lot of patients with various movement disorders, and all of them have some different variable movements like essential tremor, dystonia, dyskinesia, and also Parkinson's disease. And what we are using in our daily practice are a lot of rating scales to measure the severity of these patients. For example, the MDS-UPDRS for Parkinson's disease, Twister scale for dystonia, or Berg-Van-Masten dystonia rating scale, and so on and so on. And all these scales are very essential, but they are all built on the same instrument that we already use in the restaurant, the human eye. Yeah. So, and this is something that's tricky. I mean, the question is, how reliable is our visual assessment? Or a better question is even, how reliable is your visual assessment? Let's test this, okay? So here, this is a patient with an essential tremor of the arms. And we use rating scales such as the Farn-Tolosa Marine Tremor Rating Scale. This scale ranges from 0, that is no tremor, to 4, that is a severe tremor, based on the amplitude of the tremor. And if we do this together now, starting with the right arm, I think we agree that it's not a 0 and not a 1. So it's between 2, 3, or 4, right? So who votes for a 2? Hands up. Who votes for a 3? And who votes for a 4? Okay, very good. And left arm, oops, sorry. Oh my, all right, sorry. I got it back now. Okay, now you already see the solution here, okay? So right side is 5.2 centimeter and left side is 6.6. This tells us that our human eye is variable even within the room here. Yeah, a lot of you raised your arm with a scale of 4. Some of you said it is a 3. So what we can see here is that estimation with our eyes is really hard to perform to get really reliable measurements. And if we get back to dystonia now, one has clearly to say that dystonia is very heterogeneous from the clinical expression, and the clinical spectrum is very wide. Yeah, we're talking about patients with generalized dystonia affecting the whole body, patients who have focal dystonia, like affecting the neck or the head, or patients that have task-specific dystonia, like the runner's dystonia or writer's cramp. And for example, here there is Charles Barkley visible here, a basketball player who has a so-called golfer's yip. So this kind of dystonia only expresses itself when he starts playing golf. So it's very, very variable and heterogeneous. And the question is, how can we really assess severity if we have such a heterogeneous disorder? So the question for me here is, can AI make visual assessments more objective? So before answering this question, we have to agree on one thing. So what is AI? So I thought that AI is like this one here, a digital talking head, or like these guys from Star Wars, yeah. So our helpful robot companion, or Skynet and Terminator. AI is a threat. So what I'm talking about are not these kind of AI. I'm talking about AI as artificial neural networks. So this is one of the AI, let's say, subfield that I'm using. It's called computer vision. So this is a subfield that focuses on automated capture, analysis, and interpretation of image and video data. For example, application that we can use is for face recognition. So you can see here, this is my face. Yeah, there's a mesh on my face, and this is recognized by an AI tool that's called MetaPipe from Google. Or it can also recognize gesture recognition, in this case, my hand. Yeah, you can see that the AI tracks all the fingers, all the digits. Or it can also detect objects. For example, this is me. I'm a person, that's good, yeah, but only to 81%. So that's a rather bad news. But the good point is AI can learn with data and with training. And when I checked several weeks ago, I'm now 92% a person. Yeah, so this is something that's really improving. So how can we integrate AI into our diagnosis of movement disorders, and specifically dystonia? So this is an AI tool, a network that has been published 2018 and has been used for animal models. So it's also called, it's called Deep Lab Cut. It's called a software package for animal pose estimation. And you can see here that there are a lot of animals such as a mouse, Drosophila fly, or here this is a forepaw of a mouse. And there are a lot of markers on different anatomical positions of these animals. So what you do is you have to feed this artificial neural network with a lot of video recordings, and you have to train it. You have to tell the program where you want to label the anatomical hallmarks. Yeah, and once the software learns this and you train it very well, it can detect all these parts of the body by itself. And this is something that we have done in several years ago in one of the first projects. This is a normal rat in a so-called tail suspension test. So you hang the rat, you just grab the tail and you hang the rat like this. And this is a dystonic rat model. It's a DYT-TOR1A rat model where we performed a nerve injury of the right hind leg, and it develops some dystonia-like movements. As you can see here, the right hind limb is somehow cramping, and we scored this kind of movements that the animals have, and we could see that there is on one hand this kind of coordinate plot that differs or that distinguishes normal wild-type animals that do not have any genetic mutation from the animals that have the DYT-TOR1A mutation. And we could distinguish some motor features to discriminate between these two models. So this tells us that AI-based kinematic analysis was possible to use in our model, but the question for me is, of course, as a medical doctor, can we also use this in human? And here you can see a patient where we also tracked a lot of marker, including the face that you cannot see properly here. But as you can see here, the markers, for example, on the neck and also on the shoulders are staying locked on the positions even though the patient is moving. So this tells us that this kind of AI-based tracking works very well. You can also see that there is such kind of coordination plot here. And during those days, there were more and more development of AI-based computer vision tools, such as this one here. I've shown you already, this MediaPipe Studio. And you can see that this patient has, again, a mesh on the face. And we not only get such kind of coordination plot, no, we go now one step further. We can turn this video recording into kinematic measurements. In this case, you can see that the AI recognizes whether the head is turning to the left, to the right, back, forth, and so on. And with such a tool, the question is, can AI be used also clinically for our patients? And I can tell you, yes, it can, in two ways. So we've performed a first study here that we published 2 years ago with over 100 video recordings from dystonia patients that either had cervical dystonia or generalized dystonia. And the patients also received deep brain stimulation of the GPI. And what we found out now, only by analyzing patients in a seated position, and with a face forward, and by turning their head in all directions, is that the AI can distinguish between dystonia subtypes. So it could distinguish between generalized and cervical dystonia. And the most discriminating feature were the oscillation amplitudes, so it's a tremor actually. And what's more to this, we, as I said, we analyzed patients with GPI deep brain stimulation, and the AI could tell us which patient benefited from the deep brain stimulation and which of the patients were before deep brain stimulation. So this tells us that AI could really show us information about the treatment response. So this tells us really that the AI video tracking adds real clinical value. Now, if I go back now to my animal models again, and as you can see here, it's not really comparable, right? In this case, I'm grasping the tail of the animal, something that's difficult to do in patients, of course, right? And the question is, how can we translate these findings? And I needed a form of dystonia that can be translated or reversely translated back to rodents. And as you all know, there is this kind of task-specific dystonia, in this case rather cramped, that can often be induced by an overused task. Of course, it's difficult to teach rodents how to write, but you can teach them how to press the lever. Okay, and this is what we did. So we trained our animals to press this kind of lever 2,000 times a day, 3 days a week, over 5 weeks. And this is what it looks like. Here you can see such kind of operant testing chamber. There is a reward dispenser. The animals get sucrose solution when they press the lever. And this is the experiment actually, okay? Some training of 2 weeks, and then afterwards 5 weeks of overuse training, and then we use this deep lab cut software to really track all the digits and all the fingers of these animals. And as you can see here, these are first results of these animals. This is a wild type animal, as I said, without any kind of mutation, and this one is a DYT-TOR1A rat with the mutation that we find in patients. And have a look at the forepaw. Yeah, there's a difference of how the animals press the lever. The wild type animals, the healthy ones, press the lever with only their fingertips, and the forepaw looks quite, let's say, normal. Yeah, but if you look now to this animal, you can see that the animal presses the lever with the whole paw, and if you look at the digit, it looks somehow overstretched, yeah, somehow dystonic. So this is something that's really visible. And also, if you look at the trajectory, so let's say the movement itself of the forepaw, you can see that this also looks different comparing the wild type to the dystonic animal. And you can see here the variability of the trajectory that's much higher in the dystonic animal compared to the wild type group. And this tells us that indeed this overused task leads to some dystonia-like movements in our animal model. And there are many other analyses that we perform. For example, this is a so-called multiscale entropy. It tells us something about how irregular the movement is. What you can see here is that the regularity of the movement is getting higher over time in the wild type animals, so they train how to reach the lever very fast, while in the dystonic animal, you can see that the irregularity increases over time. So they become worse and worse when they do this kind of lever press task. So what can we do with such a model? We can now go back to the patient again. So I cannot teach animals to write, but patients can press the lever, of course. And that's what we are doing at the moment. Yeah. So this is a healthy subject who is doing this kind of lever press, and we will compare these movements from the patient, or let's say from a healthy subject with the movements of the animal. And the same we're doing for the dystonic animal. We're then training dystonic patients to press the lever, and we are then comparing what kind of kinematic features are similar and which are different. So this is something that's ongoing in my hospital right now. And with this kind of translational research, we're trying to extract features that define dystonic movements, both in animal models as well as in patients. Now, why do we use animal models? Because in these models, we can dig deeper into the pathophysiology. And we can, for example, look at network electrophysiology. We can look at cellular mechanisms. Yeah, we can cut the brain of the animals and look at cells. We can look even at plasticity. So really high resolution dendritic spines can be analyzed. We can perform things like PET analysis. Yeah, getting the whole brain of the animal and look which kind of regions of the brain are changed in their metabolic activity, and we can look at molecular mechanisms. And what do we do now with this AI-based kinematic tool for cervical dystonia patients? So at the moment, we're running a study in Germany over 12 centers, and I'm very interested in botulinum toxin. What we're doing now is we are recruiting patients with several dystonia who receive botulinum toxin injections, and we are tracking the patients over one cycle. So we will document what kind of muscles have been injected, and then every second week the patient will record a video recording of him or herself, and then upload this onto our server so that we can use this AI-based tool to objectively analyze the patients over time and really identify what kind of changes do we get if we inject certain muscles. And this will hopefully lead to information such as an objective longitudinal monitoring, the treatment dynamics under botulinum toxin treatment, time course of response, and we hope to be able to optimize therapy by such a study. And since we're at the moment with 12 centers actively recruiting patients, we hope to get quite a lot of patients so that we can really get some information out of this study. This is another study that we are doing also with the same, let's say, pipeline information. This is a so-called biomechanical model. And what you can see here, this is a skeleton where you have all the muscles programmed that are responsible to turn the neck and the head. So these models are available. We're training it. By training, we can then identify really what muscle is doing what, and by implementing the data that we get from the injection study, we hope to identify really also functionally which muscle really does. And this is a 2D model, but we are also now building a 3D model. This is a setup that we have established in Würzburg, in my home city. You can see 8 cameras, and all these 8 cameras are synchronized so that we can really assess movements of the head and the neck of patients in real time and get from these 8 cameras really a 3-dimensional model so that we get the dynamic of the movement of the head much better than just by using a 2-dimensional model. And this will help us to get into more detail about the pathology of such movements and of the abnormal postures. And we can also use this kind of model to simulate new therapeutic options. Yeah, for example, one can think about to virtually test therapies such as botulinum toxin, long-lasting ones or whatever. And then what's happening if you just inject one muscle, and you can simulate the turning of the head if you inject a muscle, also regarding the position of the injection and the dosage and so on. So all these things can be tested hopefully soon with such a model. So, and there's another study that I want to present to you, and this is something that's where I really need your help. Yeah, and this is a European video repository for dystonia that I would like to build, and I would like to ask all dystonia Europe members to record a short video recording of themselves, yeah, by sitting on a chair and record only the upper part of the body, like this one. This is, by the way, AI generated patient. Okay, so this looks quite cool, I think. Yeah, and we will then upload both the video recording as well as information about the medical history and some questionnaire about also things like quality of life and so on, onto a secure system that's called RedCap. It's a research electronic data capture system that is used across Europe and is secure. The data is then saved at our servers at our university hospital. And we will then use all these data and the video recordings to analyze this kind of kinematic movement that I've shown you. And as I said already, the study I've shown you was done with 100 patients. But if we get video recordings from across Europe of as many as possible dystonia patients that are members of Dystonia Europe, I guess we will get really a whole repository that is so big that we can really train the network to be excellent. And I believe that by doing so, we will have a lot of new information. For example, I think we can better perform diagnosis of dystonia, maybe even perform or identify some new subtypes of dystonia. things that we cannot see by just by using our eye, something that the AI can maybe see. And we will also generate or develop an easy-to-use app for patients using this kind of pipeline. And I think this is something that goes in direction of personalized therapy across different treatments. And here, this is actually a system that's already running. You can see here that there is a QR code. If you like to, you can just scan the QR code with your handy, with your cell phone, and click on it. This is the general link to patient's information and consent. Yeah, if you try this, you can see that there are then 25 different languages available, where the patient can click on the right, let's say, language of choice, and then click through the information and give his or her consent to work on this project. Yeah, and then the patient needs to put in the name and the birth date, as well as an email address, and sign digitally. And once this is done, within 48 hours, this information goes to the University of Würzburg, and someone will check, for example, if the patient is old enough, 18 years plus, if the email address is correct, and so on. And if this is okay, then within 48 hours, each patient will receive a personal link. Yeah, you can also try this one if you like to. And this link, by the way, is used if you use, for example, a laptop or so, and you can just type in the link. And this one you can use, for example, with a tablet or with a cell phone. Yeah, so it works already. But this is only, let's say, it's not the personal link yet. It's just to show how it works. Okay, and this link then leads to the survey that asks things like, like the medical history of the patient. For example, what kind of dystonia form does the patient have, or what is the year of diagnosis, who made the diagnosis, is a gene mutation present, and so on, and does the patient use botulinum toxin or deep brain stimulation, and so on. And there's also a patient quality of life questionnaire, the EQ5D, that looks like this. There are 6 questions, very easily to click, and 1 question regarding pain. And in the end, you get to this site here, where you can download the protocol for how to seat yourself in front of the camera, and how to record a video recording that we can use for this kind of analysis. And then you click on this link here and upload the video recording. And this goes to Würzburg, where we can do the analysis. Yeah, and this is the protocol that I wanted to show you. Yeah, so the patient, or the digital patient, is sitting here just in front of the camera. Then is asked to turn the head to the right, to the left, up and down, tilt the head, and just close the eyes, open it. That's it. Yeah, it takes 2 minutes or so to get this. And afterwards, once you have uploaded everything, the survey and the upload is finished, and that's it. And we can use the data now to train our network, to try to build a really nice repository where we can really perform a very sophisticated kinematic analysis of the dystonia, let's say disturbed movements of all kinds. And so in summary, I hope I could show you that AI adds an objective, reproducible layer to clinical symptoms, and that AI can extract scalable kinematic features, so we can classify dystonia and objectively quantify and optimize treatment response. And by use of AI via this patient-powered European video repository for dystonia, I hope that we can really improve the kind of kinematic analysis, movement analysis that we nowadays have. And I mean, this whole session is entitled "What the Future is Bringing Us," and I think actually that the future is now. That this kind of application can be ready to use soon. Yeah. With this, I'm at the end of my talk, and thank you for your attention. This is the group. Oh, thank you. Yeah.
Sit down, please. That would be great. We need a handheld mic as well that is turned on. Perfect. Thank you. Okay. So any questions burning from people for our two looking into the future presenters? Okay.
Hello, I have a very ill-defined question here from you, Mr. Chi Wang Ip. Is this, do you consider this learning assisted or non-assisted? So, because if it's non-assisted learning, then maybe the AI finds new patterns that you haven't, and classifications that I haven't thought of before.
Yeah, that's right. So, I mean, these kind of AI tools need to be trained first. This is something we have done already. So what I have not shown you in the beginning is that, of course, we still need to tell the AI first what we want, what we are looking at. Yeah, for example, we have used the Twister scoring in the beginning, done by experts to rate all the patients that we include in the study, and then compared to what the AI told us regarding turning of the head, angles, and so on. And we found a very high correlation after training the model. And now I think we are in a shape that we can indeed try to get more and more video recording, more data, and see what else does the AI bring us. But we need the validation from the experts. Yeah. That the things that we see are really, let's say, meaningful, because sometimes you get also data where you do not know what is the clinical meaning of this. Yeah, and this is something that one needs. But I think that I believe that the more data we have, the better the AI becomes, the more sophisticated it becomes. Yeah, and then at one point we will get to know or to see some more features regarding dystonic, let's say, phenotyping that maybe we as observers miss in the beginning, but then maybe suddenly we see it.
Yeah, thank you.
I have a question regarding genetic testing. It's not really, I'm not really asking for myself, but as part of Dystonia Europe, we sometimes get questions, you know, why doesn't the doctor just take a blood sample and test? But as far as I know, that's what I'm asking, it's not as easy. It's not just a blood sample or a blood test to find a gene. Because sometimes we need to answer the people that asks, and you know, like you said, when it's not young people, you know, it's the economic aspect, etc.
Right. So, I mean, thanks. I understand. So technically, it's quite simple. Of course, a genetic test works by obtaining a blood sample and sending to somebody who does this analysis, and usually then provides a result. The main problem is that, if you have this kind of late onset dystonia with no other signs and symptoms and nothing else, like typical cervical dystonia, for example, starts in adults, the chance that you really would find something is so low that it's not really. We talked before, we should maybe educate people in ultrasound-guided injections instead and invest the money there rather than doing analysis that they're not cheap, and maybe it is. So this is the thing. If you do it 100 times, maybe you find one or two, but it's just not very common. So that's the main reason why it's not done. And that, of course, also means that we can only find what we know, right? There might still, I'm not saying that adult onset dystonia is not at all genetically caused. It might still be, but at the moment we don't know what to look for. So this is a number of reasons why at the moment genetic testing is not recommended for people with adult onset focal isolated dystonia. And the situation is quite similar, for example, for Parkinson's disease that I also work a lot with. If you have late onset Parkinson's disease and nothing unusual, genetic testing doesn't help at present. There's a lot of research, but no, not for a clinical diagnosis.
Gentleman at the back.
Hi, one question for Dr. Wang. What do you think? Can we use this also for diagnosis of dystonia?
You mean when?
Diagnosis.
Yeah, when
in first stadium?
When we can use it?
Not maybe just for familiar doctor, not for neurologist.
So what I think is that of course this kind of development still needs some time and effort and money to be done. But I think so. These two studies that I told you about will or are already started or will be I think accomplish something like next year or so. And next to this, I'm also developing an application already. To be able to use this also in patients, and I'm then trying to set up a clinical study using this application, and compared to, let's say, non-app use regarding, for example, the injection of botulinum toxin, to see whether the app can tell us which muscles are good to inject and so on. So these are things that I think will come within the next 2 years or so. And I hope actually that this kind of application can then be given to neurologists, practitioners, so that they can really also use the app to screen patients with dystonic symptoms, and the app can tell the medical doctor whether it's going direction of dystonia or not. So within the next 2 years, I'm quite sure that there will be some kind of development, because in our hospital we are doing a lot of things like this. I'm interested in dystonia. We have people who are very much interested in using this kind of computer vision based analysis on Parkinson's disease, and this development is going so fast. Every week you get some more new tools from the companies like Google, Meta, and so on. They develop this kind of pipeline so fast with so much data. For example, this kind of meter pipe data I showed you for the hand tracking or for my face tracking has been done with, at this stage, with 30,000 healthy subjects. Because these companies have this kind of many healthy subjects available, and what is difficult for us is to get so many patients. But if we get the patients, we will be very fast, and I'm sure that we will develop this within the next 2 years or so.
So, I love the work you're doing, especially
Thank you.
in the digital health technologies. And one of the questions I actually had, because I might have missed that, but you just mentioned it, what is the platform you're going to use in the future, right? Because in some way it has to be an application as well, and if that could just capture all the movement. Then my question goes into CE marking, GDPR, and things like that, because that is often an issue directly when you do that. And how are you thinking of solving that issue? Because that is what we're also trying to solve a lot in our own applications.
I think this is really a problem. At the moment, I'm still on the scientific track, let's say, and I can tell you about the application. The data I've shown you was developed, or the results we got on a server, right? Of course, with a high, let's say, with a lot of power, but we managed to build the same kind of analysis tool already on a tablet. So this works already, and the thing that's ongoing at the moment is that I'm trying to program a software that is good to use, and this is something that will come soon, I guess. And then, as I said, I'm going to start a clinical study and see whether it works out well or not. And about this, all these regulation things, there I have to say I have to rely on people at our university. So we do have people who are in a digital technology field, and who told me that all these kind of developments regarding digital technologies are becoming more and more, let's say, often submitted to the regulations departments, and that's why it will be easier now to get these things done, yeah, and I hope this will be like this, yeah, and as I said, I depend on those people at the university where I'm working at to help me with this kind of things, yeah.
Anyone else? Monica.
So, how many videos do you wish to receive from Dystonia Europe patients members? What is the goal?
I remember we talked about 17,000 members. So
Okay.
at least 16,999 would be good.
So, all leaders, we have a lot of work to do.
He clearly mentioned 30,000. I heard that.
So what is important? This is something I already discussed with Monica. This is this pipeline that I've shown you with the QR code is always in development. So we can improve this, all time. And what I would like to do is really to send this to you first, to the board members, that you really just check whether everything that is important also for you is included, or where you see hurdles. Maybe something is too complicated. I just developed this by thinking about, okay, what would be interesting for patients, to me, but I think what's important is that you tell me what should be changed, and if I know this, then I can tell the people who are doing programming to change things, and then we should also meet with those people that you can tell them directly. And I think once everyone is satisfied, then we can launch it, because I really would like to reach as many patients as possible. And I believe that if we have problems at the beginning, then we will not reach every patient. But if we can work on this together to get this on a level that where everyone thinks, okay, this can be used for patients, then we will get a lot of information, a lot of surveys done, a lot of video recordings where we can work with.
Yep, lady at the back.
I was wondering, well, I think your work is absolutely great in terms of diagnose and follow-up of the effects of all kinds of therapies. But one of the challenges of dystonia patients is the very long way to a diagnose. Do you have any plans to open up your application so that neurologists or even house doctors can use it to diagnose a motion disorder in general?
Yeah, sure. This is the plan. Yeah, I mean, it's once we reach a stage where we really think or believe that this this kind of let's say program can detect dystonia and also severity of dystonia really let's say reliably, then the plan is really to open this, because I want to have a tool where the diagnosis of dystonia is much easier, much faster. I mean, just yesterday I talked to someone of the members who told me that the problem is really the diagnosis. It's the delay of years until the diagnosis comes. If you're lucky, you meet some neurologist or some practitioner who has seen a dystonic patients before. If not, then it might be that you get undiagnosed for years. So this is really the idea. Yeah. And what I haven't shown here is that, of course, at the moment we have trained this this network using old video recordings from patients who were sitting on a chair only. But this kind of model I've shown you, this biomechanical model with the neck muscles and so on, this is something that's also in development. There are people who have already published, for example, whole body models where you can see every muscle of the whole body, and this is something that's also in the pipeline at the moment. Yeah, so I'm building next to this 3D head movement analysis, now a 3D whole body gait analysis set up at my hospital with 6 to 8 cameras, hoping that we can then also look at the whole body. Yeah.
Just one last question. Going back to when you developed this app, who is owning the app? Is it Würzburg? And who is funding this, and who is owning the data coming in as well? Because also just the data coming in and the server capacity, it costs a lot of money each year. Who is paying for all that? And do you plan on that physicians or patients should pay because it costs money or how are you getting the funding?
So at the moment, I really have a very, let's say, scientific interest in this, yeah. So that's why at the moment I did not think about who's going to pay for the app in the future, yeah. So because for me the important thing is that we have an app that we can give to patients and medical doctors just to work with it, yeah, and not to earn money with it. The other question is really the development of these kind of projects and apps. This costs money, and this is at the moment a case that I'm paying it with, let's say, third or grant monies from what I receive from different let's say projects, and at the moment we have a so-called it's a research consortium. In Würzburg, in Germany, where I'm part of, and we are working on pathophysiology of dystonia, the role of deep learning simulation, and this kind of projects also fall into this kind of consortium. That's why I'm also paying this kind of research through this kind of money. And but you're totally right, yeah. So that's why I'm also talking a lot with the companies, for example, yeah, and just to see how we can facilitate this kind of projects. I can work on the projects on my own with the team that I have, and but of course, if there is a possibility to get grant money, it will be much faster to drive this kind of projects forward. But in the end, the plan is really to develop something that can be free of use, that can really just help patients and medical doctors to treat patients better.
But you need continuously funding. You need funding all
that's
the time.
Always all the time.
So that's quite a lot of money.
Are there any online questions that have come in? Yeah.
Sorry. Okay.
Thank you so much for this nice lecture. I have one question, because aren't you too optimistic about family doctors that you can just look at that app and make the diagnosis? Because what I'm thinking is, shouldn't it be a supportive tool when someone thinks of dystonia? I mean, if you're a family doctor and you don't know much about dystonia and you see someone with an abnormal posture, you think this might be dystonia, then I can think it can be helpful. But there are many other reasons why a neck is not in a straight position, and that's not dystonia, and they are not in your video protocol. So I'm a bit worried about this. I think it's too optimistic to say, okay, we have the app, look at the app, and this is cervical dystonia. Do you agree or not?
Yeah.
I'm not a pessimistic person, I'm a very optimistic person, but it sounds like for me that saying within 2 years, I don't think so, to be honest. What do you think?
Yeah, thanks for the question. Yeah, I mean, of course, let's put it this way. Within 2 years, I think we will have something running, yeah, something that we can use. The more data we get to train such a network, the better it becomes, yeah. So if we have then, for example, video recordings, analysis of patients, at range of, I don't know, 100,000 or so, at this time, I think we will get something that's really, really good. And I believe that it's a matter of time, when we all will be using such kind of apps. I mean, this is of course focused on dystonia, but I know that there is a lot ongoing also, for example, for other disciplines like internal medicine and so on. A lot of people are using this kind of AI-based kinematic tools or tools to really analyze their kind of diseases, and I believe that if we have a lot of people working on these kind of tools, and at one point try to bring these things together, then these kind of tools can help to differentiate potentially different diseases. And of course, but what I agree on is that, as I said in the beginning, I don't think that we can omit the observer, the medical doctor. These are tools only to really support the medical doctor. As I said, the second lens, in sense of really helping to assess different kind of diseases where the medical doctors might not have that experience, but of course we still need them. And I think really it's a matter of time, where we get to. Maybe within 2 years we will get this app, as I said, for clinical study, maybe to identify the muscles and so on. But let's say in 10 years or so, I'm sure that we get something to help us to better diagnose patients. Mm-hmm. Yeah.
Any more? No? Okay. Well, I think, thank you, gentlemen. I know that before we close and let people go for coffee, I know that Monica and Jill wanted actually a final word, but on their behalf, thank you to all our speakers for, I think you've done past, present and future in a day, so thank you so much to all our speakers. Thank you.
This is for you.
Thank you very much. Thank you. Thank you. Very nice.
You did it. I didn't feel like have to be fair. Yeah.
Andreas, can I tell you something?
Oh, you want to?
No, I can take with him.
Okay. Oh, you want to?
Yeah. When I exercise in swimming pool on rehab,
do you want to use this?
It is often my dystonia go to be very strong, but I do it anyway because I think it's good to exercise. But when I go out on the step, the hur säger man personal? Staffs going to help me in the shower. It's very powerful, but I think it's good to train a little. But when you said here, the guys who exercise so and be worse, it's same for me.
It is on.
So the question was about if exercise, if you should exercise also you get worse dystonia symptoms. So the general advice is not to do too much exercise. That actually strengthens the muscles that are very active in your dystonia. But that of course depends very much on the individual situations. If you know that you have one particular muscle that is always very active, there's no need to train that even more because it is very well trained already because of dystonia. But of course you should do this kind of training that is just aerobic training and you know that you feel well afterwards. So that I think you. I'm not sure how. No, I think whatever you feel you feel good of afterwards is usually okay. There's no need to really do training of muscles that are active the whole time because of dystonia, because they already are very strong anyway, so you don't need to do training of their strength.
When I started, it's very, my body is calm.
Mm.
And you longer the time go in the water, it's being
Okay,
worse.
okay.
Yes.
Interesting.
But I think it's good to training a little.
I think so. Keep going, I think.
Thank you.
Okay.
1 second.
Is this on? Yeah. So we're coming to the end of the day, and I think I want to say, like Andreas, it's been wonderful to meet all of these wonderful people from lots of countries in Malmö, only 10 minutes away from Lund, where we both live. Otherwise, you and I, we have to travel to these meetings. So big thank you to everybody for coming here today. And thank you for all the wonderful presentations. We have learned a lot. We have become more educated as patients. And I also hope that you have been able to connect to one another and met new friends, new people from different countries. And also before ending, I would like to promote this conference that we are organizing together with the Dystonia Coalition in Sevilla, in Spain, 7 to 9 April in 2027. And it's an international dystonia symposium for the medical experts, researchers. So there are leaflets, and you're welcome to take leaflets and bring to your treating neurologists and medical experts that you know. And then we can take the next one. And you know that this Dystonia Day is happening every other year. So this year, Malmö, Sweden, and in 2 years, it's actually our 35th anniversary of Dystonia Europe. And we will then be in Belgium and probably in the city of Leuven. So I hope to see as many as possible of you there for a 35th anniversary party. Yeah. So I think that's from me, and then it's you, Jill. Yeah.
Yeah. Thank you, Monica. Just a little bit of business from me. I'm sorry, I do need a note because I've not got a good memory. Yeah, could you please all remember to complete your evaluation forms and leave them behind, maybe on a desk at the back there. And could you also please leave your name badge and lanyards, because we do reuse them. And I would just like to echo the thanks that Monica has just given to all our wonderful speakers. Thank you to Rachel for moderating so well, making the whole day run seamlessly. Thank you to Monica and Maretta for all their hard work, and the rest of the board for their work too. And we look forward to seeing you at the next conference. Yeah. Okay. I do beg your pardon, I did forget one very important thank you, and that's to our sponsors. Without them, this event would never happen. And that's Mertz and Ipsen.
Thank you. For those of you who go with us to a guided tour of Malmö by bus and then to a dinner in a Viking village, we meet at 10 minutes to 5 in the lobby at this hotel.